will you please call roll, sir?
This is Chris Sykes, certainly. Laura Carroll,
Good morning, present.
J.K. Costello,
Here.
Morgan Honey,
He's excused.
Amanda Jaslinski,
Present.
William Kennard,
Here.
Barry Martin,
He's excused as well.
Kasana Littler,
Also excused.
James McLaughlin,
I'm here.
Christina Mulkey. I am searching for. Oh, there is Miss Mulkey now. I will promote her to a panelist.
Can you also promote the panelist, please?
Dr. Mulkey, are you with us? Oh, you're probably coming over.
Hi, Chris, I'm here.
Hey. And David Pump.
Good morning.
Good morning. We have a quorum, sir.
Excellent. Thank you very much, Chris. All right. The next thing is public announcement. The date and location of the next Medical Service Board meeting is scheduled to be held Friday, May 8th, 2026, beginning at 0900 or 9 a.m. virtually and in person at 320 West 10th Street, second floor conference room, Pueblo, Colorado, 81003. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed caption is available on your Zoom toolbar and staff will chat out instructions. Please identify yourself when speaking comments. They are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholders' input in alignment with the department's mission and in the best interests of Coloradans. There is testimony sign up for the open forum and for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. After public testimony for a rule or public comment begins, we cannot accept any additional signups. We will provide multiple opportunities to sign up before the deadline. Public comment will be limited to 2 minutes. At the end of 2 minutes, your time will be up and we will move on to the next individual signed up to testify. Thank you very much. And I just want to say thank you in advance to everyone for keeping an eye on those rules because that allows us to hear from everyone and gives us an opportunity to hear everyone's opinion. So thank you. Next, department updates.
Hi, good morning, everyone. Can you hear me okay?
We can.
Yes.
Thank you very much.
Okay, great. Sorry, this is Adela Forrest Brennan, Medicaid Director at the department. And I've had a crazy morning, so I pulled over to Starbucks so I could give you the department updates, and then I'll get on the phone and join you and drive on in. So it's been a busy couple of weeks for us. As you are likely aware, our Executive Director resigned about 2 weeks ago. Today is her last day. In the meantime, Gretchen Hammers, who you may remember, our former Medicaid Director, about 7 or 8 years ago.
I am so sorry. You're breaking up. Is there can we postpone this until you get in a better spot and then we'll come back and revisit you?
Yeah, sure thing. Will do. Thanks.
Awesome. Thank you. Thank you everybody for your patience with that. Next, let's move on to approval of the minutes for the last meeting. Did everybody get a chance to review the last meeting's minutes? Yep. All right. Is everybody comfortable with that? Can we get a motion to approve the minutes from the last meeting, please?
This is David Pump. I move that we approve the minutes as is.
This is Laura Carroll. I second.
Thank you, Madam Chair. We have a motion and a second. All in favor, say aye.
Aye.
Any opposed? Any abstentions? All right, so that carries. The minutes are approved as written. Next is final adoption of Rule 1. So, Bonnie, if you could go ahead and give us your presentation, please.
Thank you, Mr. Chair, members of the board, people in the community that are both in the room and online listening. My name is Bonnie Silva, and I have the honor of serving as the Director of the Office of Community Living. I am here today to present several rules. The first one up is MSB 260225-A. I want to note that the department received a lot of public testimony related to a different rule that we've not yet brought in front of the board, related to a 56-hour per caregiver cap. I just want the community to know that's not the rule I'm presenting today. But what I am presenting today are rules related to high growth LTSS areas, specifically around community connector, personal care, homemaker services, and health maintenance activities. And we have some soft caps and some limitations that I will present to the board for final adoption. Again, not the 56-hour per caregiver cap is being presented today. So I just want to provide that clarity in terms of what's coming forth. There's several other rules being presented on the agenda, but again, not the 56-hour cap. So I just want to provide that clarity up front. If we could go to the next slide, please. So as the board knows, I think it's important before you hear from me or my colleagues presenting some of the rules that we are changing in relation to sort of Medicaid sustainability, looking at how we can make sure that our programs are sustainable for many years to come, that I ground our presentations. I won't do this in every presentation, just a reminder as to why we are here where we are at today. As you know, Medicaid comprises a significant portion of our state budget. And Colorado has made several significant, important, intentional investments, specifically in long-term care over the last several years, things that we should be very, very proud of. These investments have reduced barriers to care. In some cases, they have expanded eligibility. They've certainly strengthened community-based supports, and those investments have mattered and they have improved access for many Coloradans. Unfortunately, today we are kind of sandwiched between the impact of federal policy changes. When the HR 1 bill passed, that resulted in a $1 billion deficit for the state of Colorado. And we have a state structural budget deficit on top of that. Without action, Medicaid will outpace other revenues in the state, meaning that if we don't take these strategic actions now, nearly every single new general fund dollar will need to be dedicated to Medicaid, leaving no other funds for other obligations. I think another key factor that is often not talked about is that the federal medical assistance percentage, or you'll hear it called the FMAP, is computed from a formula that takes into account the average per capita income for each state relative to the national average. By law, FMAP can't be less than 50%, but it can be higher. So based on Colorado's income compared to the national average, we receive the lowest federally allowable FMAP. But unlike other states that are receiving that 50% match, we have a spending limit because of TABOR. So again, these factors can get pretty nerdy and technical pretty quickly, but it's important to understand that we have a spending limit, we have the lowest FMAP, and we have a lot of fiscal challenges before us that have required us to act extraordinarily quickly in a compressed timeline. When you factor in all of these investments, when you factor in all of these factors and the previous investments to LTSS, you can see that our program growth does not align with the available funding that we have. And that is a very hard truth, but that is the truth that is before us today. And if we don't take targeted action, costs will continue to outpace the money that we have available. I recognize that these discussions are not abstract. The decisions impact the people who rely on these services every day, and I know that they are hard. Our goal is to make thoughtful adjustments now so that we can preserve access to these services over the long term and avoid deeper reductions in the future. If we can go to the next slide, please. This slide demonstrates in terms of long-term services and supports that our expenditures have increased from, really, if you look at, just looking at from 18-19 to 23-24, that we've had just some rapid increase. And the trend has required us to look at outside of those intentional investments, like these are not all surprises to us, but where has utilization or a reimbursement structure or a policy design contributing to unsustainable cost growth? And so the regulations that we're putting before you are really aimed at targeting those specific areas. If we can go to the next slide, please. So onto the rule that is before you for final adoption. The benefits that we are talking about within this rule are community connector, personal care, homemaker, and what's called health maintenance activities, which is a self-directed version of like skilled care services. And you can see why these services were targeted for action between either the increase in the amount that we're paying, sometimes triple-digit increases, certainly double-digit increases minimally, or the increase in the number of hours per member per month. So a lot of increase in utilization. So when we were looking at where do we want to make potential changes, we wanted to look at making changes where we would have impact, and this is why these services specifically were targeted. If we can go to the next slide, please. So in looking at the overview of the rule, this rule implements targeted sustainability actions and clarifies other sections of the rule to support really consistent authorization and use of this benefit. Specifically, the annual limit for Community Connector is going to change from 520 hours per year to 260 hours per year. A member and their family can use those hours however they want. So they can save it up for the summer or distribute it equally over 12 months. So it's a per year limit. It adds language establishing a soft cap for personal care, homemaker, and health maintenance activities, along with an exceptions process to exceed those soft caps if it's warranted. If a person's illegal, we will have a process to review that and allow for that. It also reduces the monthly limit for legally responsible persons. A legally responsible person is a parent, a legal guardian of a minor, or a spouse that may provide homemaker services from 10 hours per week to 5 hours per week. If we can go to the next slide, please. This rule also creates cleaner language regarding parental or legal guardian responsibility for personal care, homemaker, and health maintenance activities, and for Community Connector. When looking at authorization, we saw that was consistently an area of confusion. We identified the need for clearer regulatory direction regarding tasks that parents or legal guardians are expected to provide for their child. So there are tasks, for example, that normal parental responsibilities that are considered normal parental responsibilities and therefore not considered reimbursable by Medicaid. An example would be a child with a significant disability, maybe H2, is going to need to have their food prepared for them no matter what. So a 2-year-old meal prep is not something we would pay for. But a child who is 16 and has a significant disability would typically be able to help prepare for their own food. So meal prep might be something that we would pay for, just as a for example. This rule also clarifies the purpose of the Community Connector benefit and adds reference to the age-appropriate guidelines that case managers are expected to use when authorizing services. In addition, the rule creates definitions for age-appropriate task standards for children and task standards for adults. These tools are not new. They were already in rule and already used operationally by case managers. The purpose here is clarification, not creation of a new standard. And finally, this rule removes the outdated nurse assessor program, references from the health maintenance activities section, and aligns the rule language with our current statutory and operational practice. If we can move to the next slide, please. So since I was here in February seeking emergency adoption of this rule, we have been working with stakeholders. And my team has worked with them to understand really where revisions were necessary and has made some pretty substantial revisions based off that feedback. One of the most common requests from stakeholders was greater specificity regarding the exceptions process, including who submits the request, what the documentation is required, the timelines for review, documentation responsibilities and review criteria, case management responsibilities. My team expanded the exceptions process language to more closely align with rule and operational practice. They revised the language that identifies responsibilities for case managers supervisors, and the department, and added clear timelines for review criteria to support transparency and consistency. We also heard that stakeholder feedback about the confusion between the age-appropriate task standards for children and task standards for adults, which are part of our direct care service calculator, and the age-appropriate guidelines used to support community connector authorization. To address this specific confusion, the rule includes the citation references in the community connector section and incorporates the direct care service calculator by reference, which was a direct stakeholder request. Finally, stakeholders requested revision to the actual task times within the calculator tools. The use of these tools have been approved through prior rulemaking, including MSB 2511, 23-C. The task times themselves are not included in regulation. However, we are very committed to continuing to work with stakeholders outside of this rulemaking process, and they're definitely in agreement with that. So this rule will define the tools for clarity, but it does not revise the task times themselves or change the required utilization for these tools. Next slide, please. I want to take a moment and address some of the written testimony just proactively that we received this week. I think there was some concern that we don't have federal authority to make these changes. While it is very common for us to seek federal authority concurrent to seeking MSB authority because the timelines have to coincide that way, we have received state and federal authority for these particular changes. CMS approved our off-cycle waiver amendment, which were effective April 1st. CMS also approved our state plan amendment in March with a April 1st effective date. I also want to take a minute to address the confusion that we have heard around the implementation of the new community connector limit. We received information just this week that there was concern that we were implementing it retroactively. And so we dug in really deep to try to understand like what is happening here. None of these changes are retroactive. And again, we're in this fiscal crisis. So this is not typically how we implement changes. Usually we do everything at somebody's continued stay review, but because we're trying to get savings as quickly as possible, we've kind of split the difference. We've said, if your plan is in the beginning of the plan year, we're going to implement it at your annual plan. If your plan is in the later plan year, we're going to implement it at your quarterly monitoring. What we found out was that for Community Connector, because of how those hours are utilized, right? They're often chunked in different ways, that felt really unfair to do it at a monitoring visit and could have a disproportionate impact. And so made the decision to just implement the Community Connector piece at that annual plan year only to make sure we're really being equitable with this particular change. So also want to highlight that for the board. That communication just went out yesterday, maybe the day before, sometime this week, I promise you. The days kind of blend together. Additionally, there have been concerns about the soft perhaps violating EPSDT. I think it's important to understand that The federal authority those services are under are Community First Choice. Community First Choice, or CFC, is an optional state plan benefit that lets us bring what are 1915C waiver services over to the state plan. CMS, in their sub-regulatory guidance, has stated that like waiver services, these services are not subject to EPSTT coverage provisions, but instead are available to supplement EPSTD services. However, I just want to highlight again, the department is not proposing hard limitations, even though we could put them in place. We want a soft cap on all of them with an exceptions process, which is permissible under EPSTT guidelines. CFC is a state plan optional services. We may set limits in terms of amount, scope, duration of services. We certainly appreciate the concern being elevated. I have deep policy experts, but we don't always catch everything. And so we're always happy to run those traps. And in this particular case, we are pretty solid. Next slide, please. I want to end the presentation of this regulation just with, I think, reiterating where I started. I understand that these changes are extraordinarily difficult. I know that they create real concern and impact for the people that we serve, their families, providers, case management agencies, advocacies, communities. These are not easy decisions. And at the same time, they are very targeted adjustments designed to improve consistency, place guardrails around unsustainable utilization, and preserve for many years to come access to LTSS. We deeply appreciate the stakeholder feedback that we have heard, and we believe that that feedback has truly strengthened this rule and the continued engagement throughout this process. I respectfully ask that the board vote to adopt MSB 260225-A.
Thank you. Do we have questions from the board?
Thank you, Dr. here. First of all, thanks for that presentation, and I know my fellow board members who did stay up late last night looking at all the comments that came in. They were read and they were attended to. I think you really, for me, hit a lot of the high points. The retroactivity one was sort of a clear pain point that it made sense to clarify. So thanks for doing that. And likewise, the legality, the compliance with federal, state, and other statutes, that's beyond the expertise of me. And so I'm going to thank you all for clarifying that and sort of, to me, making that less of a key point. The bigger picture I wanted to ask about was, that's a huge investment that's been made, especially in the community connector in the last 5 years, right? As I can understand, I mean, tens of millions of dollars. And in the context that we're working in right now, including having a recently resigned executive director, is there evidence that that investment has paid off in the sense of decreasing institutionalization? The tone, and rightfully so, of a lot of the comments was you got people exercise, right at the very edge of their human capability to look after these really challenged kids. And one of their compelling arguments is, if I'm pushed over the edge, my kid's going to end up institutionalized, and that's going to cost everybody a lot more than this investment. So and frankly, I think the department has to do this, has to be accountable for how we spend public's money. And if we're spending it and it's really saving on institutionalization, I will support those expenditures all the time. But if it's not, if it's simply if institutionalization has been like this, and expenditure on these aspects of things has gone through the roof, I think I'm going to be personally much more ready to have a lot of scrutiny on those things. So that's to wrap up. What's happening with institutionalization costs? Has this investment in a concrete way impacted them.
Bonnie, you have a,
Thank you, Mr. Chair, and thank you, Dr. Kennard. So Colorado, through our investments, it's something we should be very proud of. We have decreased the number of people with disabilities being institutionalized year over year for the last decade. And considering we're serving nearly 100,000 people, to have, you know, such a large percentage decrease year over year, I think it's like a 5% decrease year over year. It has been pretty phenomenal. And we have done such a good job with children in particular that we don't have institutions for kids in Colorado. And so I think that where we look for kids is where do they end up in hospitals unnecessarily for long periods of time, and how do we make sure that we can support them in the community. That said, I mean, I think one of the areas that clinicians get a little bit hung up is, you know, you guys look at very medical metrics of, did this do the thing that we said it was going to do? And in home and community-based services, it is a habilitative model. And it's often the suite of services that we're providing that are life-changing and life-saving and really help somebody have a quality of life as defined by them to appropriately live in the community. So I want to maybe change the frame of reference a little bit. And also for Community Connector in particular, I think it's important that we go back to COVID, when we went from having a diverse array of providers to, for the first time, we had the opportunity to allow parents to receive payment to provide services. And that was so essential when we didn't want anybody coming into a home to prevent the spread of COVID. And so we allowed for it. And following the end of the public health emergency, CMS changed their guidance. Historically, they have said, no, they can't provide things like Community Connector. It's not considered extraordinary care. We would not pay for it. And they said, yes, they can. And so we had to pivot our guidance and said, okay, well, if we're going to allow this, what are the parameters we're going to put in place? And again, I think family caregivers are essential to our healthcare ecosystem, and we allowed it. And then we saw costs go up. And so we put additional parameters in place, and that didn't control costs. And then we put additional parameters in place, and that didn't control costs. And we've done several things before we got to the point that's before the board now. And at this point, we're massively reducing the rate. We're cutting the units in half. And if this doesn't work, then we will have to remove the allowance for parents to provide services, because we have to keep the service available for the children that need it. And let me be clear, I'm not blaming parents. They aren't authorizing the services, and they're not the provider seeking it, right? We have, they are sort of at the center of this, but we are trying to maintain the service. And so the thing that changed was allowing parents to provide the service. And there was, I think, a group of providers that centered around that business model and ways that we struggled to keep up with effectively. And what we saw was the service was also not necessarily always being used in alignment with our policy. So we are very hopeful that these changes will bring the policy in alignment with a way that will make the service sustainable for the kids that very much need it for the long term, and right size it. And if not, we'll make more changes. Sorry, that was a long story.
no, thank you very much. I appreciate that. Dr. Kennard, does that answer your question?
That was a very thoughtful answer that gave me some good history about the impact of COVID on this as well, and the challenges of returning to some not really normal state. So thank you for that.
Yeah, I echo that. Thank you very much. Dr. Kennard, do you have any other questions?
So thank you. So
Madam Chair, did you have a comment? Oh.
Hi, everybody. I just got off. My mute wasn't quite not muting. Good morning, everybody. Hi, Bonnie. Thank you so much for your presentation. I really appreciated how much time you've taken to cross all the T's and dot all the I's that were giving people anxiety. And there's just one other one that I want to make sure we're hitting on, and I'm going to ask you to do it so that I don't do it wrong. A lot of the comments that I saw were, and frankly heard in my own community, right, was single parents and this concern about that 5 hour, 10 hour thing. You know what I'm talking about, Bonnie, right? And my single moms in my community, I have two people who are very dear to me who actually fall under all of this, who are single moms. And that 5 hours difference to how they manage their family to them is a giant thing, right? And we all agree to that. And I know us, and I know HickPuff, and I know we are not trying to slight or short these single parents, right? That's not what we do. But I was wondering if you could take a second to really speak to it so that there can be a higher level of comfort within our community as we move forward in voting on this.
Bonnie?
Thank you, Mr. Chair. Thank you, Madam Chair. That is, thank you for bringing that up. I had intended to address that in my presentation and I failed to. Yes, it is heart-wrenching to read the comments from single moms. As a single mom, anything that we're doing that might disproportionately make it harder on that particular community is difficult. Again, I'm going to ground us in the why are we making these changes, and that is that we are in a fiscally unsustainable spot. And so the option for me, and this may in fact happen, is to limit it to one legally responsible person, not two. And so there isn't an option to authorize more for single parents. It would be at this juncture authorizing less per family given the fiscal state that we're in. And that is something that we're considering from how do we make things equitable in terms of how this shows up across different family structures. But at this juncture, trying to move forward with what is on our plate. So we have heard that feedback. I understand that it's difficult, but we're not in a position to offer more hours at this juncture.
Thank you, Ms. Silva. Madam Chair, did you have any additional questions or?
Well, I just want to make sure I'm understanding then. So we are saying that if a child is fortunate enough to live in a household with two parents, they're entitled to 10 hours of care. But if they're in, because that is what you said back to me. And then if there's a single parent, then it's only 5 hours. Because I figured for sure these people were misunderstanding the rule as it was written. Can you please help me understand how they are misunderstanding this rule?
Thank you, Madam Chair. Ms. Silva?
Thank you, Mr. Chair. Thank you, Madam Chair. So what's important here is to understand is we're actually not limiting the number of hours that a child can receive, right? So if a child genuinely needs 10 hours of homemaker a week, we're saying you can continue to have 10 hours. What we're doing is placing reasonable limits on what a legally responsible person can provide. So that is looking at nationally, what's the standards? How can we make sure that our policies are in alignment with that? So the limit here is a per legally responsible person. The limit is 5 hours per week. And understand for people that have two partner households or two legally responsible people in a household, that might have a difference. And again, we're looking at that, but the number of hours that child can receive is not being limited.
Thank you, Madam Silva. Madam Chair, did you have any additional questions or comments?
I think that answers my question. It seems to me that you are saying, Bonnie, that if more than 5 hours is required in a single guardian environment, that they will have the opportunity to apply for those difference in hours. Is that correct?
That is correct.
Great. Thank you. I appreciate the clarification. Thank you very much. I yield my time.
Thank you, Madam Chair. Sorry. Amanda, go ahead.
So this is Amanda Jashinsky. Can I say it a different way and see if I'm understanding what you're saying correctly, Bonnie? So a child is entitled to the hours they need. That is determined. But an individual parent, it has been deemed, can only provide up to 5 of those, can only be paid for up to 5 of those hours that child needs. So let's say a child needs 10 in a single parent household, 5 of those hours could be provided by the parent and the other 5 hours would be provided by another entity or individual. Am I understanding correctly so far?
Sorry, Ms. Silva.
Mr. Chair, thank you. Amanda, that was very well said. That is the policy.
Okay, so then I guess my question is. So the limits end up having to be. We're not limiting the hours a child needs, we're limiting how much each individual could contribute. I do think though that it still causes an inequitable situation when one family is able to receive twice as much because they have two individuals within that family unit that can provide the hours towards the total that the child needs. So I guess I'm wondering how have you brainstormed, like how can we, I recognize the limitations per person, but how can we make that more equitable? Because it just does seem like a glaring issue if a certain group of people has the opportunity to get twice as much.
Ms. Silva, do you have a response for that?
Thank you, Mr. Chair. Thank you for your question, Amanda. I think that it's important to understand that from a policy standpoint, we have to look at what is the policy for the member, and then we have the opportunity to place legally responsible limits on. Sort of household income cannot be a consideration in our policies. I do think in this piece, what we could do reasonably say reimbursement is limited to one legally responsible person. And that is, in terms of brainstorming and given our fiscal environment, something that we are considering as we're moving forward. But given the totality of changes that are before us, it is not something at this time that we are moving forward, but it is something that in response to this feedback that we have and are continuing to consider.
Dr. Jaslinski.
Just one follow-up question. This is Amanda Jaslinski. Some of the testimony suggested, why is the limit not per household then rather than per individual? And I guess my question is, or just to clarify, am I understanding correctly that that's because the limits have to be per caregiver from what you were saying earlier, that you have, like you were saying, you looked at national standards and so forth, and so limits have to be placed by like individual human being rather than by household, and as you said, this is different from the hours that the child receives totally, that's calculated separately, but in terms of this payment structure, it would have to be by person.
Ms. Silva.
Thank you, Mr. Chair. Thank you, Doctor. The limits are usually placed on legally responsible persons, right? So there's family caregiver limits. And so when we are looking at how do our limits compare to national standards, and how do we make sure that we're in alignment sort of with what other states are doing, you know, looking at legally responsible options, especially following COVID and what we've seen with our trends, it's one of the things that we've looked at. And so we looked at limits sort of per legally responsible person. Again, we can look at saying, enacting a policy that says there's only one legally responsible person allowed to provide care. That is an option on the table. It's not one that we're currently moving forward with. And that would create a more equitable policy for people that maybe only have one legally responsible person. But at this juncture, we're not moving forward with that. It is something that we're considering, and I hear it.
Thank you, Dr. Kennard. I saw you. I want to get to David Pump first, though. He's had his hand up for a while, and then we'll come back to you if that's all right. You bet. Awesome. Thank you. Mr. Pump.
Thank you. Bonnie, I really recognize that this is a difficult situation and we are dealing with issues that none of us want to be dealing with and having to provide limits that nobody wants. I recognize that. I do want to understand though, what is the actual boots on the ground process for a legally responsible person? In this case, I'm going to say mom, who needs that 10 and she's alone. How is she supposed to get that 10 that her child is able to have? How is she supposed to do that in an equitable way?
Ms. Silva, your response?
Thank you, Mr. Chair. Thank you, Mr. Pump. I really appreciate the question. So, we have been working with case management agencies and providers and again, going back to making sure that if a child really needs 10 hours of caregiving, that should be part of their plan, and working with provider agencies, making sure that they're bringing in other providers to render that care. And mom might be a caregiver, and hopefully they're bringing in other caregivers to support the broader caregiving needs.
This is David. So we recognize that there's a provider shortage for that other 5. I hear that again and again and again. So it almost feels like it's a non-starter on the 10. Should we just say that there's a limit of 5?
David, Madam Silva?
Thank you, Mr. Chair. Thank you, Mr. Pump. The workforce challenge has been something that, my team has been working on for the better part of the last decade. And so I will not give you a Pollyanna-ish answer and tell you that everything is fine. But I will say that we have grown our network of providers year over year. And I also think that, if we've talked to providers around, they have been overly dependent upon family caregiver models. And we have invested over $500,000 in rate increases to help them bring in direct care providers and diversify their workforce. And so I guess I'm not comfortable with saying you're only going to get the 5. I am comfortable with saying, let's work with our case management agencies and our provider groups and making sure that we're doing the best that we can to wrap around every single person to staff the needs of the person receiving services appropriately. And it doesn't mean it's always going to happen. It doesn't mean that for the last 20 years that it's always happened, but we need to work collectively together to try to make that a reality.
Point taken. Thank you.
Anything else, Mr. Pump?
I'm good. Thank you.
All right, thank you. Next, we'll go back to Dr. Kennard.
Thank you. Mr. Pump's question encompassed mine, so I don't need to be redundant. Thanks.
JK?
Yeah, this is Jake Costello. Question for you. I don't know much about this world, so but if you can characterize, and obviously there's not an average family, but are most families in this situation only utilizing a legally responsible person, or do they have outside help? Question 2, is that outside person providing services across different billing categories? So like is the same person coming in and doing community connector and homemaker services, or they have separate people doing each of those? So I'm trying to just wrap my head around what this looks like from a member standpoint.
Ms. Silva?
Thank you, Mr. Chair. Thank you, JK, for that question. So I'm going to go back to what I talked about, sort of the shift that we saw post COVID-19 and the shift after the federal government said parents can get paid to provide service. Prior to that, they had very rigid rules in place, and when we could authorize parents to provide services in particular, and we had some pretty stringent caps in place even when spouses could provide services. And so I think that the care landscape shifted in ways that we didn't anticipate. And so historically, we had, I think, a diverse workforce come in and support people. And I'm not saying that doesn't exist. I am just saying that over the last 5 to 6 years, we have seen that move more and more into a family caregiver realm. And I think that we're going to have to move into a more diverse sort of workforce moving forward. And again, family caregivers are essential to our healthcare ecosystem. So this is not a way to say that they shouldn't be providing care. But we do need to look at what are the right limits around that to make sure that, again, the authorization is fiscally sustainable for the long term.
Thank you, Mr. Leck. JK, any other questions?
No.
All right. Any other board members have any questions? All right, Ms. Silva, I did have a question, comment, really. This is James McLaughlin. This one's hard for me. I think it's hard for all of us. We struggled with this a little bit last month too. I think I want to echo what the rest of the group has said. You've done an amazing job coming in here, answering much of the concerns that we've heard from stakeholders over the last month. I also want to acknowledge one other thing. I've had members of my community actually come to me and share support for this, which is kind of interesting too. People who are actually receiving these services, because they have seen some folks, they feel like the service as a whole could be in jeopardy if we don't get this spending under control. And I think they're right. I do. Also, I'm a single dad. My kids are all grown up and out of the house now, but I was a single father and I raised 4 kids by myself. So I saw those taxes and those charges that you pay for being a single parent that you don't see when you have the privilege of being raised by a 2-parent family. So I am super sensitive to this. Also, my brother is the sole caregiver for an adult child who receives some of these services in another state. So this is it's pretty important to me. And I guess what I would like to ask is, if somebody found themselves in this situation, they're a single parent, is there a process through this rule? Is there a process where they could apply for more than the 5 hours to be the caregiver? So I'm a single parent, I provide these services. Could I apply to get the 10 hours and be that caregiver for those 10 hours? So go ahead.
Thank you, Mr. Chair. I really appreciate your question. Again, the policies that we are creating have to be based off the member need. And so an exceptions process based off the need of a single parent is not something that's allowable in Medicaid. So it's important to say, like, I know it sounds a little harsh, but it's not a policy that we could put in place. That said, we're talking about homemaker services. There's an entire suite of services, and there's still other opportunities for if that parent happens to be a paid caregiver, for them to get paid for other services. It's not just limited to homemaker. And so there's not an exceptions process for that parent to get paid more services for the homemaker piece in particular. We do have other options as we're moving forward through other tougher decisions in terms of workforce shortages, but not for that one. Again, I think that this is an area where we feel like it's really reasonable. 5 hours a week is still very generous when looking at national standards around homemaking and legally responsible people. When we look at our adult side of the shop, we can see that they're bringing in outside care pretty consistently. So while the children's workforce hasn't been there, it is there on the adult side. And so we can look at how agencies can expand that. And paid family caregivers that want to diversify outside of homemaker can certainly have the opportunity to do that. So I know it's hard. And we are also trying to figure out, like, how do we make the best worst decisions and bring our budget back into alignment with something that's far more sustainable for many years to come. And this feels very, very reasonable.
I appreciate you. Thank you for the statement. Just one follow-up. It really does sound like if this spending doesn't get under control, the restrictions are going to have to be tightened, that the rules are going to have to be tightened even more, and people could potentially suffer more in the long run if we don't get this figured out. Is that a fair statement? Ms. Silva?
Thank you, Mr. Chair. That is an accurate statement. It is not just a fair statement. When we look at, again, long-term care is an essential component of Medicaid, but to say that these services don't need to be part of the solution is inaccurate. We grew by $1 billion in just over a year, $1 billion. And so, there's some people that's like, just take across the board cuts. Well, if we do that and we don't look at what's actually driving the expenditures, then we're going to stay on the hamster wheel and keep having to do cuts to the point that we don't have any providers, because nobody will provide the care for rates that don't support, what it costs to provide the services. So really what I'm trying to do is show you with the data is that we're looking where the trends, what is driving that growth in ways that we didn't quite anticipate. And then what are we doing to reasonably bring it back in alignment so that we can better have predictability in our spending, we can better ensure access for the long term, and make sure that we're not having to make deep, painful, irreversible cuts over the next few years if we're trying to sustain what we have.
Excellent. Thank you, Ms. Silva. I guys see any more hands over here? Any other questions from any of the board members online? Mr. Sykes, do we have any public testimony?
We do, and first we're gonna call up Tamika Brahm, because Tamika has joined us in the room.
Tamika, can you come join us? Thank you very much. Thanks for being here. Mr. Sykes, if you guys could put a 2-minute timer on the.
Looking at you, Kelly. Okay.
Oh, he's already started. We can, Kelly, is it possible to reset that? Thank you very much.
Thanks, buddy.
Ms. Brown, are you good? You need a second?
Sure, so I was gonna do it from here, but I'll do it from here, so.
All right, whenever you're ready.
So, good morning and thank you for having me. I do want to begin with your own words. Your policy requires that services are based on an individual assessed need and that a person-centered support plan addresses the individual's goals, needs, preferences, unique strengths, abilities, and risk factors. But the system you're implementing does not do that. Instead, it relies on an age-based calculation, one that assumes individual functions according to their chronological age. Many members do not. They are being compared to neurological age standards that do not reflect their actual functional abilities. This is not individualized care. It is not person-centered planning. And it raises serious concerns, and I did hear you, about EPSDT. Under EPSDT, Medicaid must provide all medically necessary services to correct or ameliorate a child's condition based on the individual's needs and not premeditated formulas. If a policy limits services in a way that prevents a child from receiving medically necessary care, it is not compliant. And I want to be very clear, a soft cap that restricts access to medically necessary services functions as a hard cap. If families cannot obtain approval based beyond that limit, if case managers cannot meaningfully adjust the services based on need, then the cap is not flexible in practice. It is a barrier, and that barrier violates EPSDT. Your own policy states that plans must be updated and warranted by members' needs or changing condition, and that members must be offered choices in regarding to their services and supports that they receive and from whom. And it is an arbitrary age-based calculator that does not allow changes in needs. And if the service allows for true choice and does not allow for medically necessary care to be delivered, you cannot claim that compliance with federal law is implementing a system while that it limits care based on age instead of need. Children are not averages, and they are individuals with legal rights. If this board intends to uphold its own policies and within federal Medicaid law, then its approach must be reconsidered, because policy, it is unlawful. Thank you.
Thank you, Ms. Brown. Do any members of the board have questions for Ms. Brown?
This is Amanda. I have one question.
Sure.
If it is a soft cap and it is flexible, and you are able through review to get addendums to it and things like that. Would you say that that meets the PSDG standard?
I would, but as we're hearing, it's not a soft cap. It is a hard cap. And I hear Bonnie saying that we can do these things. Have you looked at the exceptions?
Which exception?
The exceptions that are written in here. The exceptions are only based on certain things and they're temporary.
So just sorry, this is Amanda again, just to clarify.
Sure.
Your concern are that the exceptions are not broad enough in scope to
100%.
capture all the needs.
100%.
Thank you for clarifying.
Cool.
That's my question.
Awesome. Thank you, Dr. Jaslinski. Anybody else have any questions for Ms. Brown? Thank you, Ms. Brown. Thank you for coming up here and taking the time to testify. Appreciate it. Do we have anyone else for testimony on this rule?
This is Chris Sykes. We do. We have Megan Bowser.
Online? Okay. Ms. Bowser, good to have you with us again. How are you doing today?
I'm all right. Thank you for having me.
Absolutely. We'll give you 2 minutes. Start when you are ready, ma'am.
Thank you all. My name is Megan Bowser. Again, I am the Executive Director for Family Voices Colorado, and I'm also the mom of 2 children who receive services, including many of those that are outlined in this rule. First, I would like to express gratitude to Healthcare Policy and Financing for the extensive work they did on these rules between the emergency rules and now, and with us between the initial adoption and this final adoption around these rules and getting the wording correct. I think it's incredibly important for us to have these rules in place sooner rather than later, as we need the rules to refer to as the implementation has already begun on many of these rules, specifically those around the exceptions process that the initial rule was very vague on. The final rule will have the emergency rule was vague on, and the final rule is much more extensive in that explanations. While I sincerely wish these rules were not needed, that these changes were not needed, that the budget crisis we are in is not the place we are, we recognize that that is not the reality. And given the reality of the budget situation, we commend the department for the work they've done to do the best they can to sustain these systems long term. I wanted to take a minute and chat about the legally responsible person homemaker cap in response to many of the board's questions around that, and just take my professional hat off for a moment and put on my personal hat and say that I do have an outside community or an outside provider who provides homemaker services for my children, both who qualify for homemaker services, because frankly, I don't want to do it. And under the CDOS model that was expanded with Community First Choice, I can actually pay somebody a high enough rate to get outside providers to provide that. So while that's not the case in all situations, it is a possibility out there. And I think there are options for families to not be left without any support. Thank you, and happy to answer any other questions.
Thank you, Ms. Bowers. It's always a pleasure to hear from you, and thank you for all the involvement in these processes and all the work you do to advocate for the community. Are there any members of the board that have questions? All right. Thanks again, Ms. Bowser. Chris, do we have anybody else for testimony?
This is Chris Sykes. We do. We have Shannon Moore.
Excellent. Shannon Moore online or?
Yes.
Ms. Moore, are you there? Ms. Moore, can you hear us? Mr. Sykes, do we have her online?
I see her online. We are
Why don't we-
asking to unmute. Ms. Moore, you're gonna have to do something on your end of the call. All we can do is ask you to unmute.
Let's give her a couple more seconds, and if not, maybe we can come back to her. Ms. Moore, are you able to?
Hi, I just got on. Sorry about that.
Oh, no need to apologize. We're all still learning the technology stuff, right? It's a different. So, thank you for being here, Miss Moore. You have 2 minutes. Please start when you're ready.
Okay, my name is Shannon Moore. I'm the parent and primary caregiver of a medically complex child here in Colorado, who relies on Medicaid services to safely remain here at home. Currently, households with multiple waiver members still receive authorization for parent caregivers, to be able to provide care higher than a single family home. In my daughter's case, she requires vesicostomy care, a daily bowel program, and will require mitrophanol catheterization in the future. These involve very private medical supports that she only allows me to perform, not even her father. These are not tasks that can realistically be transferred to outside providers. So I'm just wanting to make sure that there's exceptions to understand privacy nature. I respectfully ask the board to ensure that these rules changes do not create unequal standards between families with one waiver member and those with multiple waiver members, and that medically necessary parent caregiver flexibility remains available. Thank you for your time.
Thank you very much, Ms. Moore. Any members of the board have questions for Ms. Moore? Thanks again, Ms. Moore. Chris, who's next?
This is Chris Sykes. We have Leah Brom signed up. I know some people came into the room. Leah is in the room with us. Thank you.
Ms. Brom, it's good to see you again. I think you've been here with us before, correct?
Good to see you.
Yeah, thanks for being here.
Of course.
2 minutes when you're ready.
I'm here just addressing obviously the task standards and everything that we've been discussing. My biggest issue is these task standards are based on age. It doesn't specify chronological age or functional age, which are two very different things if you have a child with an IDD. I have an 8-year-old who's more like a 2-year-old due to his genetic condition called Lowe syndrome. I find that wildly, like, I can't even believe this is a discussion that we're having. Disability is not based on age. So the tasks shouldn't be based on age. It should be based on the child's disability and what their service plan requires. That's just my 2 cents on that. Part of the reason that there are no children's institutions in Colorado is because of paid family caregivers. That's a huge part of it. Just addressing what she said earlier. I am married. I happen to be married and have another caregiver in the house. So I don't have to worry like single caregivers do or 24/7 caregivers do. I'm fighting for that community because I find it wildly inequitable. And the fact that it's just you're out of luck doesn't seem acceptable to me at all. I also have colleagues that have kids that cannot have other caregivers in the house because of their extreme anxiety and fear. There's been countless issues with abuse, and children that are non-speaking cannot explain what may or may not have happened to them. There are so many risks that go along with that I don't think are even being considered. I can't even I'm so glad that Megan can get hours. That's fantastic. I would love to get 2 hours of respite away, and I can't even get that. So I don't know where I'm supposed to find a caregiver, because I actually work for a case management agency, and I have yet to find any kind of provider that can help me on a larger basis, other than my husband. We've tried so hard. We've told our stories to you guys, and I just beg you to please listen to the people that it's happening to. I can't, I don't know what else to do. Please. Thank you.
Ms. Brom. Do I have any board members that have questions for Ms. Brom? Okay, thank you. Chris, who's next?
This is Chris Sykes. We have Casey Barrett. And Casey is in the room with us. Wonderful. I was going to say they're having trouble finding online.
Thank you, Mr. Barrett.
Thank you guys for hearing us out today.
And who do you have with you?
This is my daughter, Olivia. I'm a single parent caregiver. She obviously, you can see she's a high needs kiddo. She's got a laundry list of complex medical needs. So I guess today for speaking after hearing some of the things being said today, the organizations that are speaking to you, that are telling you that stakeholders want a lot of these things, is completely false. Organizations like the ARC the other night, when the House was voting on the loan bill, talking about wanting us to halt all these delays and everything like that, is completely false. They do not represent families at all. Talking to, hearing, the HCPF talking with case management agencies and the stakeholders and stuff like that. My agency's never heard from PACOF at all. Not once. So, maybe some of the bigger organizations, case management agencies have heard, but they don't, I don't know. It's incredibly frustrating to hear a lot of the testimony that's being put forward for a lot of these things when there are so many families, and it's so easy to see in just a small Facebook group of 2,500 parents that are just screaming from the top of the hills that they don't know what to do, because a lot of these things that you're being pushed forward are just don't make sense. There are some policies that have been pushed forward that have gone back and forth on their reasoning, and the cost benefit is just not there for a lot of these things. A lot of parents that are looking for other caregivers that can't find them, or having things cut to the point where they will now have to look for outside employment. So you're talking about caring for a complex kid and trying to find an employment outside of the home, and also trying to find a caregiver. So it seems like a lot of times that I don't know if it's the state or the offices are just banking on the fact that parents are going to have to be giving this care unpaid because there isn't people to come in and take care of their kiddos. And for me personally, I don't trust people. My daughter, she's 14. So, and for $20 an hour, I don't see anybody that's going to be cleaning up after her.
Thank you, Mr. Barrett. Thanks for all the work you do. So appreciate it. Members of the board, do you guys have any questions for Mr. Barrett? All right. Thank you guys for being here, and thanks for your time. Mr. Sykes, who's next?
This is Chris Sykes. We have Ginny Arrington.
Miss Arrington, online.
Good morning.
Good morning. Thank you for being here. You have 2 minutes. Please begin when you're ready.
My name is Jenny Arrington. I am the parent of a medically complex child who depends on 24/7 care. Her care is her care is life-sustaining. I am here to talk about how I advocated for a system where care would be based on individual needs and where exceptions would be accessible when those needs didn't fit into a standard model. This proposed rule moves in the opposite direction. I'm hearing so much typical language for a typical child when medically complex children do not fall under a standard. I am deeply concerned about the reliance on exceptions when the system to get exceptions is incredibly hard. And it's said like it's so easy when it's not. This approach places great burden on those with the highest needs. When policies are built around what is typical and require people with disabilities to fight for exceptions that create barriers, whether intentional or not, that is how ableism shows up. Our children should not be treated as exceptions to a rule that was never designed with them in mind. They should be the reason the system works. I'm asking you to ensure that medical necessity, not standardized limits, drives care, and that any exception process is truly accessible, timely, and reliable, because we cannot We cannot access care if there's gaps in care. Thank you for your time today.
Thank you, Ms. Arrington. I really appreciate your comments and yeah, I just really appreciate you being here. Members of the board, do you have any questions? Ms. Arrington, thanks again. Chris Sykes, who do we have next?
This is Chris Sykes. We have Victoria Moole.
Ms. Mole?
Can you hear me?
Yep, we sure can. Thank you for being here. Go ahead.
Thank you for having me.
Absolutely.
I come to you today as the mother of special needs triplets. I have 3 children that were born severely premature due to no fault of their own. I had uterine cancer at the time I was pregnant. Those children were born 5.5 months early, have been in some type of medical facility, PT, OT, speech, doctor, specialist their entire lives. They are now 14 years old. I am a single parent. I can't even begin to explain to you how very difficult it is to be a single parent of special needs triplets while also trying to maintain just basic daily living or even my advocacy. I would love nothing more than to have assistance, have help. I have no social life. I don't go out and do things. If I do, my children come with me. I have taken them to more MSB and JBC meetings than I can count. The problem is, with the cuts and the caps, I would now have to find 3 different outside caregivers, providers, because it's not just the 5-hour cap or the 7-hour cap, it's a 56-hour cap. Then it's not just a 56-hour cap because now you're adding on other components that come with different waivers. I can't wrap my head around the amount of outside caregivers or providers I would have to bring into my home to meet the hours they qualify for that I am capped on to be able to meet their needs. I don't understand why it's necessary to bring in multiple different caregivers or providers to meet the very needs that I meet for them on a daily basis and have for 14 years, most of those before I ever became a caregiver. So I implore you to please think about that before you vote. Thank you.
Thank you very much, Ms. Mole. Members of the board, do you have any questions for Ms. Mole? Ms. Mole, thank you for being here and thanks for all the work you do. Chris, who do we have next?
This is Chris Sykes. We have Jessica Thurston. Jessica, are you in the room? Only because we're having trouble finding Jessica online.
It's Jerica.
Oh, Jerica, I apologize.
No worries. Yeah, so I'm Jerica Thurston, and I think the last meeting I appreciated you guys reading my testimony and trying to speak up for single parents. And I'll be honest, I was really hurt by the Megan Bowser stating that there's other options like CDAS, and that requires a volunteer position for someone to agree to do the administrative burden of payroll and all of these things with that. So I don't have anyone to volunteer. The only support person I had passed away 3 years ago. I am out here in Colorado with no friends, no family.
Ms. Thurston, we lost you. Can we pause the clock for a second and see if we can get her back?
I'm sorry, can you hear me?
Yeah, we can hear you now.
I'm sorry. Just going back to CDAS, that requires a volunteer position to oversee administrative payroll and whatnot. I don't have that. I don't have a family. I have no family, not even out of state. The only person I had passed away 3 years ago. I have no friends. I have no support system. And so that's not a solution. And as far as HCPF with Homemaker, it's not about making up hours in other areas. That's not how that works. It's based on their needs. And I can't just transition making up hours under personal care. That's that's just not how that works. And, just a week ago, and I know we're not supposed to share, public health information, but my son is 12 and defecated on, the floor of the bathroom because he's unaware of his body signals. So it's like, I have homemaker needs, and I don't understand why it would be hard to not revise it per member versus per legally responsible person when I don't have another person. I just don't. You would think that the other parent would be able to help when there's a divorce, but that's not the reality for my life. And I'm doing this on my own. And so if I can pay someone else to come out and do it, I don't understand why I wouldn't be able to provide those services, especially when I don't have anybody to provide outside services. I don't get 10, 20 hours, weeks of respite that my children are supposed to get. It's just me. So, I hear you. That's fine.
That is time. But thank you for your testimony. The music, just so everybody knows, the music has stopped working for some reason. So unfortunately, you may be cut off by my voice, and I apologize for that. Members of the board, do you have any questions or comments for Ms. Thurston? Okay, I don't see any. Ms. Thurston, thank you very much for your time. Mr. Sykes, who do we have next?
This is Chris Sykes. We have Kelly Lyons.
Kelly, are you there?
She's asking if I could read before her.
Are we fine with that? Yep. Come on up. Thank you very much. Yep.
I want to briefly highlight a core requirement of the CFC Community First Choice program under federal law and CMS guidance. The CFC technical guide makes clear that services must be based on individualized functional need delivered through person-centered planning and provided in a sufficient amount, duration, and scope to meet those needs. It also specifically addresses the role of natural supports, including family caregivers. CMS is very clear that natural supports cannot be required or relied upon to replace needed paid services. Families can choose to provide care, but they cannot be forced to do so. And in services cannot be reduced based on assumption that unpaid care will fill the gap. What we are seeing in this practice right now is the opposite. Policies like caregiver caps and service limitations are resulting in authorized services becoming undeliverable, which effectively shifts the burden back onto families, especially parents, without choice and without compensation. That is not consistent with the CFC framework. CFC was designed to support individuals in their homes and communities based on their actual needs, not to limit access through indirect mechanisms like provider caps or assumptions about family availability. I urge the board to carefully consider whether the current policies and proposed changes align with federal requirements, particularly around person-centered planning, functional need, and the prohibition of substituting unpaid natural supports for necessary services. Thank you.
Thank you very much. And if you could pass on our gratitude to Ms. Lyons.
Thank
you. Chris, who do we have next?
This is Chris Sykes. We have Rochelle Narrow signed up.
Narrow or Marrow?
Narrow.
Narrow. Awesome. Miss Narrow, are you there?
Not see her online.
Okay. Awesome. Give her a couple more seconds. She's not online, so probably not there. All right. Chris, who do we have next?
We have Michelle O'Neill.
Miss O'Neill? Do we see her online?
Kelly was unable to find Miss O'Neill online also.
All right. Let's go ahead. Who do we have next?
The next individual we have signed up for testimony is Lindy.
Lindy?
We're also struggling to find online.
Okay. How about next?
This is Chris Sykes. Next individual is Heather Sanders.
All right. And do you see her online?
Sorry.
Hello, can you hear me?
Oh, yeah, we sure can. Are you Miss Sanders?
Yes,
Excellent. Thank you for being here. 2 minutes when you're ready.
Okay, thank you. The rules we are receiving or reviewing state only 7% of members will be impacted by this 91-hour HMA cap. You must remember, though, this 7% is literally the most medically fragile members you serve, members who will literally be dead or in an institution without this skilled home care. These are also the same members that are currently receiving full denials for our private duty nursing services, full denials. My child's one of these. Literally only 3 people in our lives are trained on his care, myself, my husband, and his nurse. If we lose his nurse, these HMA hours are the only backup option that we have to afford to hire these nurses back for the additional hours that we can't provide any longer because of the caregiver caps. These HMA caps are now removing even that option for, again, the most in need members that HCPF serves. I understand budget cuts need to be made, but my proposal is to not approve the caps for HMA services specifically. These are essential, non-optional care hours to keep our medically fragile population alive. It's only been 2 weeks since this cap has been followed, and case managers are already denying going through the exceptions process for members in need, or they are restructuring skilled care hours under the personal care category, which is explicitly stated against the rules. As opposed to addressing these as caps needing an exception process, I propose the rules be simply changed to needing an additional approval step for hours over a certain limit. This gives case managers a better understanding of your stated goal to ensure members that still receive these essential care hours and not causing such a hurdle that these already overloaded case managers are trying to avoid. I also want to address the requirement for CMs, these case managers, to provide requested docs within 7 days or HCPF would deny exceptions. They're already overworked and the members should be involved in this initial request for more information. They are the only ones truly invested in the process and able to obtain that documentation within that short 7-day period. This exception process will be key to ensuring members are still able to access these essential HMA services. We need to ensure that the exception process is equitable, fair, and truly accessible to the most medically fragile members of our society. Thank you.
Thank you, Ms. Sanders. Does anybody from the board have any questions for Ms. Sanders? Ms. Sanders, thank you very much. Chris, who do we have next?
This is Chris Sykes. We have Erica Hill.
All right. Ms. Hill, can you hear us? You don't mind?
I'm here. Can you hear me?
Yeah, we can hear you. Go ahead, Ms. Hill.
Can you hear me?
We can. Can you hear us?
Yes, I can.
Excellent. Thank you for being here, Ms. Hill. Please, when you're ready.
Okay. Good morning. My name is Erica Hill. I am a Colorado resident and I hold a master's degree in healthcare administration. I am the parent and the primary caregiver of a child with Duchenne muscular dystrophy, a rare progressive life-limiting condition. I'm here in strong opposition of the changes. My son is medically complex and immunocompromised. His condition requires highly specialized, consistent care from people who deeply understand his disease. This is not interchangeable care, and it takes years to learn how to safely help him. There are times where we're physically carrying him up and down stairs and relies on a wheelchair. None of this changes just because of a policy. While I'm not a single parent, we do not have extra help. My husband is a small business owner, and if he's not working, we are not bringing in income. He's a primary source of income. I work out of the house, but I'm still providing roughly of 75 hours of care to my son. We also have another child in competitive sports, and we're balancing that as well. On top of that, my husband is a disabled veteran with his own health issues, and there's weeks where he cannot provide care. Our only additional is my son's grandfather, and he only lives here in Colorado less than half of the year. And he truly is the only one that understands his equipment. For families like mine, bringing multiple outside caregivers into the home is not just difficult, but it's a safety risk. And with rare conditions like Duchenne, finding these caregivers is not possible. I've had to walk doctors and nurses in the hospital and settings on how to use their equipment to properly care for my son. And now I'm supposed to find caregivers that are supposed to be able to do this as well. And it's already fine. I can't find physicians that truly understand this disease. From a personal and healthcare administrative perspective, reducing consistent care does not save money. It increases complications, hospitalizations, and long-term costs. Family like mine are not asking for handouts. We are simply asking for policies to reflect the realities and protect our children. When you go home today,
Ms. Hill, thank you. I appreciate your time. I'm sorry, we are over time.
Okay.
But I do appreciate your comment and thank you for taking the time to present to us today. Members of the board, do you have any questions for Ms. Hill? All right. Ms. Hill, thanks again. Chris, who do we have next?
This is Chris Sykes. We have Alexander Escalante.
Alexander Escalante, are you with us?
Check, check. Can you guys hear me?
We can. Thank you very much for being here, Mr. Escalante.
Thank you for having me. Good morning. Thank you for having me. Thank you for hearing us out. Again, my name is Alexander Escalante. I'm a CNA for my son. I want to speak from both my professional and personal experience. So when I started, I was offered about $16 per hour to provide a CNA care level for my own son. After a little negotiation, I was able to reach a higher rate, but many families are not in a position to do that. At the same time, I believe the state is dispersing anywhere, I think, from $27, maybe $35 per hour for that same care. That means that in some cases, agencies may be retaining close to half of the total funding allotted for care or allocated for care. If we're going to have a serious conversation about cost savings, we have to look at that reality. So right now, the proposal is to cap hours and reduce support for families. But again, if we're going to ask families to absorb cuts in the name of fiscal responsibility, then fairness requires that we also examine a portion of funding that does not reach the caregiver. So we can't focus only on the care being provided while ignoring the structure surrounding it. If cost savings are truly the goal, I've come up with two options worth considering. First, the state could explore absorbing more of the administrative role currently handled by agencies. By reducing layers and the middleman between funding and care, we can ensure that more of each dollar directly supports families. Second, if agencies remain part of the system, there should be reasonable limits on how much each hourly reimbursement can be retained for overhead and profit. This would ensure that the majority of funding reaches the people actually providing care, the parents. Because right now we're considering reducing hours for parents, families who are already carrying the responsibility of daily hands-on care, as you've heard, while leaving the middle layer largely untouched. I haven't heard anybody talk about this. So if we're going to cap the care, we also have to be willing to cap the system around that care. You can't medically certify a need as essential and then financially treat it as optional. So I urge you to take a closer look at where savings can actually be achieved without directly harming families and ensure that care dollars are reaching the homes they are intended to support. Thank you for your time. Have a good day. Again, my name is Alexander Escalante.
Thank you, Mr. Escalante. Any members from the board have any questions? All right. Thanks again, Mr. Escalante. Chris, who do we have next?
This is Chris Sykes. Laura. Is Monica in the room with us? Because we're finding Monica online.
Ms. Laura. All right. Let's go ahead and go with the next one.
Next, we have Bryce Rafferty.
Mr. Rafferty. Longtime friend and ally here to this group. Mr. Rafferty. Good to see you in person. Thanks for being here.
Be okay if I read as is?
Yeah, please.
Good morning, Chair, members of the board. My name is Bryce Rafferty here on behalf of CCDC in support of this rule. I want to begin by acknowledging the hard truth we've all been hearing about. We are in a historic structural Medicaid budget deficit, and this rule plainly implements utilization controls and other guardrails that may, in some instances, result in service reductions. This burden is also not falling on one group alone. It's a universal burden on the entire state, on members, families, case managers, providers, the department, and every stakeholder connected to the system. What is so important about this particular rule draft is that it reflects what can happen when people respond to a crisis with open, iterative, collaborative work. And that has happened. And I'd like to thank the department for its commitment to it. Substantial revisions that have addressed many of our concerns. Compared to the earlier draft, this version is far more coherent, clear, and usable. Definitions, assessment tools, processes, notably the exceptions processes, evaluation standards, and the relationship between those moving parts are all much more clearly addressed here. That matters because in a system under strain, everyone needs the same source of truth in a robust regulatory framework. At the same time, this rule is only foundation. Its sustainability will depend upon whether all of us continue in the spirit that produced it. The only path forward is for everyone to acknowledge the gravity of the situation, commit to sharing the unique perspectives, and maintain open communication channels at every level of the process, and face the uncertainty and hardship as a unit of Coloradans with disabilities and those who support them. So we support this rule while strongly urging continuous oversight, monitoring, plain language resources, accommodations, and ad hoc policy guidance throughout implementation. Universal recognition of this rule's imperfections must lead to universal contributions to its future. Colorado can continue in the spirit of unity, collaboration, and compromise, then even in this time of austerity and division, it can serve as an example of how a Medicaid system and the people within it can endure together. Thank you.
Thank you, Mr. Rafferty. Members of the board, do you have any questions for Mr. Rafferty? I actually have a question for you, Mr. Rafferty. This is James McLaughlin. If we fail to take action today, and we're not able to pass this rule, what are your concerns on what might happen as a consumer of services?
So, thank you. And again, this is Bryce Rafferty with CCDC. I am in a unique position, as you say, as an advocate and also as a member. The emergency rule, which we have come a long way from, that was passed out of necessity, and I think this is a rule that is necessary to put in place, given the hardships, given the annual services soft caps and the tax standards. I don't think any of us want to be here looking at this situation, but we are here. We are looking at a situation where if we don't have some sort of framework, if we don't implement some sort of attempt to make cuts to these services and the available benefit, then we will have much more draconian realities down the road. And the challenge is, how do we collectively face this with the most transparent, accountable, and accessible processes to make this an individualized assessment? Now, nothing is perfect, but I believe that we have come a long way from the initial draft. I think the exceptions processes outline criteria that are not perfect, as people have pointed out, but that allow members to see how they are being evaluated. And if they are denied partially or outright, they are able to understand why that was the case. And that was not something that was included in the previous exceptions regime, where it was really a definition. I think what has happened is, in the absence of guidance and the detail that's provided in this specific draft, what happens is you have one CMA doing one thing, one CMA doing another. There's rulemaking by memo in effect. And so I think that this is the foundation. If we don't have this, then we have disorientation. We don't have a centralized, robust regulatory framework. We don't have the means by which to challenge the services allocated with exceptions and with appeals, right? And so, yes, I would fear that we would have a much more stressful situation. I think we would be back at this table with much more dire, I mean, hard to believe, but yeah, much more dire situations for members. And that we need to approach this, and we need to also, as I mentioned, keep open communication channels. We need to inform this rule and any possible guidance and supplements and resources with a continuous oversight, a continuous monitoring, and a continuous conversation and dialogue.
Thank you, Mr. Rafferty. Anybody have any follow-up questions for Mr. Rafferty? Thank you for your time. I don't think I've ever met you in person, so it's nice to see you in person. Mr. Sykes, who do we have next?
This is Chris Sykes. We have Terry Magrins Courtney.
Terry Magrams Courtney. Are you there?
Yes, I'm here. Can you hear me?
We sure can.
Wonderful. I am a parent caregiver of a medically complex child. She is one of 6 that have been identified in the world with a very rare form of mitochondrial disease that affects that also secondary spastic quadriplegic CP, cerebral palsy. The concern that I have is I'm hearing a lot about trends and research and comparing to other states and so forth. But as an educated person, I have a PhD, and I know that statistically it's very hard to compare one program to another state program if it's different, if there are any different variables. So it's very hard for me to understand how the trends are working and so forth. The other thing as educated professionals is we all know that there is a national workforce shortage in nursing, and as having an immunocompromised child, bringing in someone into the house to pick up hours is a huge concern of mine because of risk of infection. Due to that, because of the lack of knowledge and the low pay, and because the CSMs are already overburdened. HCPF staff is already overburdened. You can hear that with their request to the JBC for more staffing. How's this going to work? There hasn't even been a pilot study run on this. We don't know if the need for institutions, we don't even have an institution in the state of Colorado that can help with children. And the burden shifts to our hospitals, which means an overwhelming amount of hospitals, long-term care, and so forth. So I am asking for, especially on the HMA caps, to not put a cap on that. And let's try the other caps that are put in place first to see how those are going to work before we dive into all of it without any background information or research to compare to. Thank you.
Thank you, Ms. Magrams Courtney. I appreciate your comments. Members of the board, do you have any questions for Ms. Magrams Courtney? All right. Thanks again for your time. Mr. Sykes, do we have any more?
This is Chris Sykes. We have Maureen Welch.
Excellent. Ms. Welch, are you there?
Hello, can you hear me okay?
We can. Thank you very much for being.
Sure. My name's Maureen Welch. I live in Arapahoe County, and I'm the parent of a former CES member, current DD member, thanks to the youth transition. Thanks for the work on improving the rule packet, but I agree with many comments you heard about discrimination of single parents, also of the lack of workforce at our current low rates. First point is we would love to see the document that Bonnie mentioned about the community connector clarification about not doing it until the CSR. I looked online and did not see any posted memos on this topic, so if she could stick that in the chat maybe through Mr. Sykes, that would be great. Number 2, regarding the community connector ability to attract non-family workforce, since it was slashed 15%, the Medicaid rate for community connector will not attract anyone. It's $20 an hour. Also, PASAs do not do any outreach for finding providers. They rely on us families to do what they call family recruitment because no one wants to work for that wage. 3, first elephant in the room, Colorado is attracting people from all over the nation. We are a destination state. We can cut all we want. We can put caps on things, but until we get a waiting period for people who move to Colorado for services, we will not control this budget. I did discover there's a 6-month waiting period for any Medicaid services to apply for in Arizona and Texas at the least. That's what I learned. Also, a more drastic measure would be to put wait lists in place for some of the waivers entirely. Otherwise, we're going to have waivers that are so watered down that they're not even helpful. The new to Colorado waiting period would be less drastic. And second elephant, we have no institutions. Where's the budget item for that? What are you going to build? Isn't that going to cost more than saving 5 hours a week here and there? And the last thing is, my grandma often said, this seems penny wise and pound foolish to save $1 million or $2 million here and there by cutting services that family want to provide when it's going to cost tens of millions to build new institutions. And my last accommodation request for Mr. Sykes is that last month I asked that you give us a couple people at a time. It's very hard to be on task, ready to speak when we're multitasking in our busy households. Thank you so much for your time.
Thank you very much, Ms. Wells. Yeah, I think you bring up some really good points there, and I'm hoping that we get when we get to comment from the from Bonnie, we'll get to hear some responses to that. I appreciate your thoughts. I think that's really important. Members of the board, do you guys have any additional questions for Ms. Wells? Mr. Sykes, do we have any additional comments?
This is Chris Sykes. We do not have any more individuals signed up to provide testimony on document 1.
Excellent. Thank you very much. So now what I'd like to do is I would like if I could get Ms. Silva to respond to the comments from the members. That would be great.
Thank you, Mr. Chair. And, I want to start by just thanking the people who drove down today and provided public comment, the people online. I hear the passion in your voice. I hear the fear. I hear just the concern, and please know that I personally take it to heart, and so do the team of people working for me on these really difficult changes. I also want to note that I feel like some of the testimony was specific to a change that, again, the rule is not before the board, but it will be forthcoming, which is we are looking to put in place a 56-hour per caregiver per week cap, which is a little bit different than the rules that are before you today. And so that's where we do have narrow exceptions processes in place versus the soft caps on personal care, homemaker, and health maintenance, which really are based off of assessed need, with the exceptions process that goes from the case manager to the case management supervisor to the department. That really allow for that nimbleness and flexibility. If you have a member with really complex medical needs, we have the process in place to sort of meet them where they're at and to provide those additional hours. I can appreciate that anytime we're entering a new process that it's inevitably going to be clunky and that we're not always going to get it right, but we have worked hard to, again, with stakeholders, especially around the exceptions process, to provide as much clarity on the front end, much guidance to our case management agencies on the front end, and worked hard with the JBC to make sure that it was appropriately staffed on our end, to make sure that it was timely and reliable. And we do exceptions process. So it's not as though it's something that's brand new to us. We have exceptions processes for many services. And so it is something that from a process standpoint that we have worked with case management agencies on for a variety of services over the years. And so we feel confident as we move forward with the soft caps in particular and the exceptions process around, we have one for Community Connector for exceptional needs. That we have the team in place to review those quickly, and to be responsive to the community, and to have the right guardrails in place to ensure that authorization going forward really is in alignment with our policies. So I just want to put that out there. I heard continued concerns around the task standards. Those are nationally recognized standards. They're not ones that we made up on our own. I get the challenge. I really, really do, with the fact that they are created for typically developing children. The goal there is for case managers to have a guidepost, not a you have to sort of be developed or performing at a particular way based off of typically developing children. We've worked hard to provide guidance to case management agencies. What we found is without that, we have people that have zero experience with children working in these roles, and they really need to have the tools and expertise in place to ensure that services are appropriately authorized and to know what to expect from a 2-year-old, a 3-year-old, and a 4-year-old. And that's not necessarily intuitive. So just to have a starting reference point has turned out to be, I think, essential. I heard a lot around services are required to be based off of individualized assessed need. I want to be clear with the community that continues to be the case and the expectation for case management agencies. Absolutely is a requirement. Again, we're allowed to have these parameters and soft caps in place. We're allowed to, from a federal perspective, to sort of put these guardrails in place to ensure that services are appropriately authorized. We will continue to work on workforce. We'll work with agencies, case management agencies, and monitor the implementation of these rules so we can make sure we understand the impact and that we're putting our efforts in the right place. One thing I did want to speak to is that there was a separate piece of legislation really aimed at gathering overhead information from agencies to speak to, I think, one gentleman who wrote hey, we're only getting 50% of this rate. We'll be collecting that information going forward as a way to make sure that we are, looking at what percentage of our rate is going to the people providing the care. We do have a base wage pass-through requirement, and this will further expand that. I know we have a big agenda. I'm hoping I touched on the big things. Board, please let me know if there's anything I missed from your perspective.
Members of the board, do you have any questions for Ms. Silva? Dr. Kennard.
Thanks. Wow, I think it was, speaking for myself, I heard everything. A couple of specific things that I think are real sticking points. One that I heard a few times was the age-based criteria. And what is the flexibility in that? As a clinician, that strikes me as borderline silly to base needs on age. We can all easily imagine how a 13-year-old might have quite a bit heavier needs than a 3-year-old, literally heavier, right? I think, well, they don't need to do this or that anymore. It just strikes me as really confusing, and it seems to be creating more grief than clarity. And so how do we deal with that? And I think the second is, I think Alexander's comments, I think were very interesting. And I think most of us that keep coming back around to that 10 hours down to 5 hours. And it strikes me that in order to get a case management agency to come up with, to pay enough to a person to provide that extra 5 hours in Sterling, Colorado, is going to be a dramatically more expensive way to do it than simply increasing that 5 hours. But I think going forward, what we really need, as you've said, is tracking and see how are we doing? Is this work? Is this right? Are we achieving what we thought we would, and at what human cost? So if you could quickly comment on age-based and how rigid that is. And I think we've revisited the 10 to 5, but you just need to know, I think people have a fair, I'm sympathetic to that concern.
Ms. Silva, do you have a response for that?
Thank you, Mr. Chair. Thank you, Dr. Kennard. So the age-based criteria, is services from a federal standpoint have to be authorized based off need, right? So part of what we're considering is what is age appropriate for anyone at their developmental stage. So what we can't do is authorize something for a 2-year-old that would be considered parental responsibility. So we're just asking that that be considered as part of their assessed need, similar to 13, 17, right? It's a component. Their standards. I want the community to hear, like, we are committed to ongoing, open, transparent communication and collaboration as we move forward with these changes. I know the time related to those task standards is something that they're going to continue to work on, but we need to have some parameters in place, because what we saw is without them, we missed the mark in terms of what was age appropriate pretty consistently. And then the 5 to 10, I am also sympathetic. I'm actually sympathetic to all of it. If I'm being frank, like, these are really, really hard changes. Homemaker services are not skilled. They are cleaning, they are cooking, they are grocery shopping. And so when we looked at that particular service in terms of when we're looking at somebody who's legally responsible, you know, allowing for, 5 hours a week for those unskilled services in particular felt like a reasonable place to start. Again, looking nationally around what parameters do we put in place for what do we allow for legally responsible people. There are no easy answers here, Dr. Kennard, but that felt like a reasonable place for us to start.
Dr. Kennard, did you have additional questions or further response?
Thank you very much.
Dr. Jaslinski.
Thank you. This is Dr. Manischewski. I think I'm trying to understand, and I don't know whether I'm misunderstanding, but back to my original clarification I made before the testimony. If a child qualifies for 10 hours, and let's say they are in a single parent household and the parent can only give 5 of those hours. And so then in that situation, additional 5 hours would have to come from an outside caregiver. How would that ultimately save the state? Or am I misunderstanding the whole thing?
Ms. Silva.
Thank you, Mr. Chair. Thank you, Doctor. I'm not sure I can pronounce your last name. Can you, Dr. Amanda?
Sure.
So in terms of looking at how we can look at our cost trajectory, there's a component of what are the right caps around what you're going to pay legally responsible caregivers. And so there is a cost savings attached to that in general. What we don't want to do outside of that is limit the care that a person can access based off their assessed need. We know that some people will choose not to bring in outside caregivers. We know that some people may not find outside caregivers. You will note that in our cost savings estimates to the Joint Budget Committee, we were very conservative because our goal is to, diversify the workforce and bring in outside caregivers. So there is some cost savings attached to it. They are relatively small, as you've heard some people testify. But here the goal is what are the right parameters around the number of hours that we would authorize for legally responsible people, while also making sure that we are maintaining access to other authorized care.
Dr. Jaslinski.
This is Dr. Manischewski. If I can make a follow-up question. So then, as you said, some families might elect not to bring someone in or can't find someone, which I can see would lead to cost savings, though I would argue in a cruel way. But then I guess my question is, the goal is more to diversify where the care comes from for the patients?
Ms. Silva.
Thank you, Mr. Chair. Thank you, Dr. Amanda. Goal is two-pronged. How do we make sure that we can sustain the cost of these services long-term? And what we saw post-COVID, when legally responsible people were allowed to get payment for services that they previously weren't, is the utilization was far greater than what we had seen before in ways that we couldn't afford. At the same time, we were investing to sort of cultivate and build up that workforce. What we know is that we don't want to only rely on family caregivers. We want to make sure that family caregivers, I think you've heard, is like, I would love not to be the only caregiver. I would like to have an option. We want to make sure that provider agencies are not just looking to family caregivers to provide care to the people that they're serving. We want to make sure that our policies and our payments are incentivizing them working to cultivate a diverse workforce. So family caregivers, absolutely essential. And also we need to make sure that they are not the only option at the table.
Dr. Jaslinski?
Thank you. I will, this is Dr. Manuel. I will mull that over. I might have more questions.
Sure.
Thanks, Ms. Silva. Any further questions from members of the board? JK.
Sorry for my denseness, but I'm trying to like put all these together. So the first part of this is soft caps on health maintenance activities, homemaker, and personal care, right?
Yes.
And so homemaker is just one of those three services. And of those homemaker services, there's a cap of 5 hours per legally responsible person. Do legally responsible people often provide health maintenance activities or personal care services?
Correct.
Often.
Right now, yes, that is the case.
Okay. And they're not limited in those, other than the caps, which are pretty large, the majority of the hours in the year, it looks like. Are they limited in those two other realms of health maintenance activities and personal care?
Ms. Silva?
Thank you, Mr. Chair. Thank you, JK. So right now, any caregiver, family caregiver or not, is limited to 16 hours a day or 112 hours a week.
Okay.
One of the other changes, again, that's not before you, is we are changing it to continue to be 16 hours a day, but no more than 56 hours a week. And again, that will be at a later MSB. And there's lots of reasons behind that. So I think that some of the testimony you heard today, but right now it is 16 hours a day, 112 hours a week.
Okay.
JK, go ahead.
JK Pesto. So I guess what I'm hearing is that this particular homemaker legally responsible person cap is a relatively small fraction of the total hours that someone currently, or even under these new proposed caps, which we're not discussing today, would be working in a week.
Ms. Silva?
Thank you, Mr. Chair. Yes, JK, that is correct.
Thank you.
All right. JK, do you have any other questions?
One more. I noted in there in the budgets, it looks like the projected savings, the biggest one is actually from Community Connector soft caps. Is that correct? Am I reading that correctly?
Thank you, Mr. Chair. Thank you, JK. I don't have the estimated savings in front of me. I apologize. But we did make some pretty significant changes there after making more moderate changes over a period of a couple of years and not having much of an impact. So there's some big changes there that will result in reductions.
One more.
Yeah, absolutely. The floor is yours, sir.
Thanks. Which of these are considered medically necessary services? Is Community Connector a medically necessary service?
Ms. Silva?
Thank you, Mr. Chair. Thank you for the question, JK. I kind of been not addressing that specifically, but I'm happy to do that. So back to the comment that I made earlier. So home and community-based services are habilitated in nature. They're not medical services. Now, so there isn't a medical necessity review. There is assessed need. Now, we have waived portions of the Nurse Practice Act and nurse aid legislation so that people can hire non-credentialed, unskilled people to provide what is very medical care. And the idea is that people with significant disabilities understand their bodies and their care probably better than most RNs that they might hire off the street to render that care. And so HMA, home maintenance activities, is a blend of what would be typically considered like CNA level care and RN level care. But again, it's not a full medical necessity review, but it is skilled type care. So I think some of the feedback you heard was like, let's not cap that. Again, it is a soft cap. And if somebody has skilled care needs that support a higher authorization, we have a process in place to support that.
Thank you.
Thank you, Ms. Silva. JK, any further questions? No.
Thank you.
Anybody else from the board have any questions? One quick one. Yeah, please, Dr. Kennard.
Dr. Kennard here. It's my understanding that there are 4 states that provide community connective services: Colorado, Kentucky, New York, and Minnesota. Is that an accurate understanding?
Ms. Silva?
Thank you, Mr. Chair. Yes, Dr. Kennard, that is my understanding as well. We are one of only 4.
Okay, thank you.
And I think the other question is that medically necessary?
Yeah.
No, again, it's based off assessed need. It is about the need to be able to integrate in your community.
Thank you.
Excellent. Ms. Silva, do you have any other comments to make?
Thank you, Mr. Chair. I appreciate the opportunity to meet with the board, to hear from the community, to be responsive. And again, I just reiterate my commitment that as we move forward through these difficult changes, to be open, to be transparent, and to be collaborative, and to look at how they're being implemented, to track and to see how we're doing.
Thank you, Ms. Silva. This is James McLaughlin. I will say, and I've said many times through this process, through the emergency bill or rule, sorry, and what we passed last night. This is hard. This is the hardest work I've ever been a part of on this board. This is not easy, and I can tell it's not easy for the HIGPUF staff as well. It's hard to say no to people who need services. But what I do hear is I hear a commitment to help people find the right services. And I believe in working with Ms. Silva and the other members of HIGPUF that there is a desire to help people find the right services. The services that best meet the needs of its members. And I've shared my personal story with you guys, and I think the one thing that I do struggle with, and as I've heard from many other members of the group, is that 5-hour cap on single families. I mean, it's a 5-hour penalty on single parent families, and it's not great. And what would be even worse is not having any services at all. And so I find myself in a really kind of not a great spot to be. But with that said, I mean, I don't want to see these services go away completely. I think we're one of 4 states that are providing these services, and I'd like us to be able to continue to do that. So, does anybody else from the board have any last thoughts or comments before we take this to the next step?
Hi, Laura Carroll here. I too am continuing to struggle deeply with this 5-hour versus 10-hour thing, when it would be something that we could very easily address with a couple of word changes. It is hard enough to be a 2-parent family of exceptional children, let alone a single one. And I also fear, and we saw this like during the 70s and during the 80s and during the 50s and 60s, where women who were in a very compromised position in a marriage being treated in ways that were unkind, unfair, and frankly dangerous to them, who found themselves feeling themselves forced to stay in a marriage that was unsafe for them because they didn't know how they were going to financially move forward. And I know that for a lot of people, this 5 hours a week may not seem like that much, but when you are making the decision of feeding your family or feeding yourself, and if you have to stay in an environment where you are physically unsafe just to make sure you are feeding your family, man, I just don't think that that is a decision that I feel comfortable making families make, especially when we could do something like, say, it's 10 hours for a child instead of 5 hours over 2 guardians. I just don't see why we can't solve this single problem, seem equitable, and stop moving backwards. Are we going to next take women's credit card rights away? Are we going to not let them sign on loans? This is how we trap women in environments that are unsafe for them. And I have a real problem with this. Thank you.
Thank you, Madam Chair. Ms. Silva, I'm going to give you an opportunity to respond to that if you would.
Thank you, Mr. Chair. Thank you, Madam Chair. I want to present the very real reality to the board that these changes have been voted on by the Joint Budget Committee. So if the desire of the board is to make sure that two family households are treated the same, then the regulation would be brought back to make sure that only one legally responsible person is billing for 5 hours a week, not to increase single parent households to 10. There is not funding for that. We do not have funding for that. We are bringing forth these changes not because we want to, but because we have to. We are in a fiscal crisis. So if that is the concern of the board, then that would be the regulation change revision that would be made. We don't have the funding flexibility to increase the hour allotment.
Got it. Thank you. Madam Chair, thank you, Ms. Silva. Madam Chair, do you have an additional thought or comment you want to make on that?
Yeah, it's pretty typical statements that we hear from government officials. Well, if you don't do what we want to do, then we're going to take away everybody's cookies. And I'm not comfortable with it. I'm sorry. I'm just not. If you guys want to bring a motion, I am definitely a no, because over 5 hours that you guys aren't willing to come back to the table and negotiate this, then yes, I am a no, 100%. Hopefully my board votes around me, because honestly, over 5 hours, this is kind of gross. Thank you.
Madam Chair, thank you. Ms. Silva, did you have an additional comment or no? Okay. Dr. Jaslinski.
Thank you. This is Dr. Manishalski. Ms. Silva, I've got another question. When you, well, not you personally, but when HCPF was coming up with this policy, why was the goal to limit care by individual who provides it to that 5, rather than just saying, let's say, if I had a child who was high needs, who qualified for 15 hours, why wouldn't I, as a parent, couldn't I elect the 15 hours come from me versus me plus people? Can you explain a little bit around that decision?
Ms. Silva.
Thank you, Mr. Chair. Thank you, Dr. Amanda. I'm going to work on your last name.
Okay.
So it is pretty typical in the long-term care space for states to have caps in place on the number of hours that family caregivers can get paid to provide services, whether in the adult space or in the child space. And that is because like funding constraints, that is the truth. And so what happened is when we looked at sort of what our hours a lot, right, which is 112 hours per week. And that was in comparison to what other states allow, right? We did a landscape review. The top of what other states allow are 40 hours a week. We are way out of alignment of what other states are allowing family caregivers to provide. So we really looked at, how can we again keep family caregivers as an essential part of our care system? We bring sort of our policies back in alignment with what national standards are. And in fact, the policies that we're putting forth now and forthcoming are more generous than national policies. I get they're really, really hard, and I don't want to be dismissive of the impact, but allow us to move forward in a more fiscally sustainable approach. The reason that you have these policies in place, and don't say if somebody needs 15 hours, let the family provide it, is that then states can't afford it, including Colorado.
But I apologize.
No, please. Thank you, Ms. Silva. Dr. Jaslinski, go ahead.
That's a very good explanation. But then here's my question. You're also saying, though, that if the child needs 15 hours, that they would still get 15 hours. It would just come from diverse entities. So that's why I'm struggling to understand, like, why does it matter? Like, at the risk of, like, why? if we are saying that we are going to allow people who require a certain number of hours to get those hours, and we will pay for those hours, but then we are saying the hours have to come from this many diverse groups, how does that ultimately save money? Because we're first saying that we will make sure that everyone gets the hours that they need. I recognize that limiting the number of individual caregiver hours could save money, but I don't see how that saves money if then we are also paying for other caregivers for the child.
Ms. Silva.
Thank you, Mr. Chair. Thank you, Dr. Amanda. So there is a couple of different factors here, and I've been trying not to dive too deeply into the individual caregiver limits because that's not the rule in front of us, even though we have the homemaker one. So let me just go a little bit broader because I feel like we're struggling to even with the 10 to 5, right? So why would states put in place limits on caregivers when they're going to authorize the hours anyway, is your question.
Yes.
Right? There's a couple of different things at play. One is there's fiscal sustainability. There's a very real, like if you have a living caregiver, whether it's mom, dad, spouse, like reasonably they can bill for a lot of hours of care. And what can we afford to provide? So it's like, you know what, we can afford to say, you know what, 40 hours a week feels reasonable. And that doesn't feel great. But that is like, it is a fiscal strategy that states put in place nationally, right? Then there's also a component of like, from a health, safety, and welfare standpoint, what is a reasonable number of hours that any caregiver should be providing? So the rule that's not before you that we sort of looked at is what do our policies allow? There isn't any sort of standard that would support providing 112 hours of care per week is a good standard to allow. So that is a component of what is reasonable. How do we provide some flexibility? And 56 hours, again, not before the board yet, is more than 40, allows for some nimbleness. We still have the 16-hour a day limit because more than 16 hours a day, again, is concerning. And then 3, when we look at caregiving models, like having only family caregivers and no diversification of workforce can actually prove to be very catastrophic for people, right? It's not healthy for their well-being. And you know, when that caregiver, say something happens, it's happened in my own family. You know, I had a family member who required total care and another family member who was their caregiver who got cancer and died 3 weeks later. Right? That was very catastrophic for them. And so like having an ecosystem of care around somebody, especially with complex care needs, is really important for their care. So when we look at what are our policies incentivizing, we took a step back and not just looked at the fiscal realities, but also looked at the care realities and said, we have to do better.
This is Dr. Amanda. So in response, and I teach back by saying it again, so I apologize, but this is how I learned. What I'm understanding is that there are multiple goals. So one goal, as you said, is to make sure that the workforce is diversified so that we don't have situations where, to like say it in one way, families are basically told you can be paid for the care you provide. So that is the option, and that is how we ensure that kids, for example, get taken care of. We don't invest in a workforce. We don't develop any other systems. We don't encourage growth in opportunities, and that's not healthy for families. So I hear that, which I appreciate. It kind of, there seems to be a goal to kind of force development of that sector that can support the children. And at the same time, there is overall a limit on, like there is a discussion on limit of number of overall hours per individual, or is that like the separate rule that you said is coming?
Separate rule that's coming, not before you today. It's hard to have.
It's hard to not put those two together. Okay, thank you. No question.
Thank you, Dr. Chislinski. Thank you, Ms. Silva. Any other questions or comments from the board? All right. I'm open to entertaining a motion for adoption of rule number 1.
Make that motion.
Dr. Kennard, please go ahead.
I move the final adoption of document 1 MSB 25-2-25A. Revision to HCBS benefits and services requirements and community first choice. Sections 8.7500 and 8.7600, incorporating the statement of basis and purpose, specific statutory authority contained in the record.
Thank you, Dr. Kennard. Do I have a second?
Name point of clarification. Please. Can I propose an amended rule, or do we have to move forward with this process first?
This is Chris Sykes. I'm going to defer to Jen, but I believe the motion on the table needs to be accounted for.
Okay.
Can it be?
No.
Removed?
Sorry. Go ahead.
This is Jennifer.
Kennard.
Yeah, I mean, I think we should make any proposed amendments before a motion.
Can I read?
Would be best.
May I withdraw my?
Yes.
motion? Then I will withdraw my motion. Kennard speaking.
I accept that the motion has been withdrawn. And is there an amended motion that we would like to make?
I'd like to make the amended motion.
Okay, JK, please feel free to make the amended motion.
I propose adoption of this with amendment to change the number of hours of homemaker per week from 5 per legally responsible person to 10 per member.
Ms. Silva, do you have a thought on that?
Thank you, Mr. Chair. Thank you, JK. What we can do is change it to 5 per member. Again, that's the budget piece.
And just for clarification, is that because that's what's been approved by the JBC?
Right, there's no funding to increase it, so I can't add the 10 per member. Like, I don't have the money to increase it, but I can say if the concern is that it's currently not equal, we could say we're gonna make the limit 5 for every household. Could put that on the table.
No, it's not.
I know.
Can I explain my reasoning, Mr. Chair? Please. My reasoning, and again, this goes to 56 hours. So, like, we're going to cut, but we're going to consider cutting legally responsible person draft, like much more than this. And this is a subset of those hours, right? These 5 hours, 10 hours. So, if hours are considering being cut by 60 per legally responsible person, it doesn't make sense to me to cut a small subset of those. It makes more sense to let folks decide how they use those hours within that 56, because the savings is not in the 5 or 10. It's in the 116 versus 56 to me.
And that was JK Costello.
Yeah, it is. That's my reasoning, and I get that, like, within the current constraints, it sounds like the amendment I proposed is not viable. You can't go back to the JBC like Jonathan and said, no, that's not how it works.
Ms. Silva, did you have an additional response?
Thank you, Mr. Chair. Thank you, JK. I can't go back to the JBC at this point, but they have their and I wish I could, and there's savings attached to it. So again, if the amendment is to everybody comes down to 5, I've been just trying to keep things steady. And I hear the inequity, but I don't have the fiscal budget to increase everybody to 10. So I just need to be transparent about that. If I did, I would do it. Would have done it before now.
Any additional questions from?
Hello, Mr. Chair. This is Laura Carroll. I don't want this to come out the wrong way. I have absolute respect for Bonnie, the department, and everyone involved, but don't threaten me with a good time. We voted against the JBC before. I'm not afraid to vote after the JBC again. And to have the guys be under the envelope of we're going to rip benefits away from families to not be discriminatory, that gives me big feelings and makes me want to vote in a way that maybe I was leaning in another direction. That is not an acceptable answer to me, and it should not be an acceptable answer to our communities either. So if you're telling me that, yes, the only way that we can be equitable is to give more people less, all right, let's talk about it. But I'm here to tell you that the JBC is not a reason for me to vote pro or con to anything. We've done it before. It's been covered in the newspapers. I am not afraid to do it again.
Ms. Silva?
Thank you, Mr. Chair. Thank you, Ms. Kara. I appreciate your comments. You know, I will maybe bring us back to where I started, and that, you know, we have had to put together key areas where we have had growth and achieve cost savings, and that is one of them. And the Joint Budget Committee counted on those cost savings and balancing their budget. And so I am just being transparent, and that is one of the things that, you know, if you all vote to say, you know what, we want to increase, I fiscally can't implement it. We're kind of in a tough spot here.
Thank you, Ms. Silva. JK? I'm sorry, actually, give me, Madam Chair, did you have any additional comments to that? Sorry, JK.
I'm pretty sure I've said my piece. Thank you. Appreciate you.
Thank you, Madam Chair. JK, sorry about that. Go ahead.
Thanks, but you're in a tougher spot if this doesn't move forward. Like there's great savings in your community connector. Nobody seems against that, and that's a huge savings. So I mean, I realize you're in a difficult position, but it seems like there's a couple parts of this that nobody's spoken against. And this like smaller part about homemaker is the hang up.
Ms. Silva, did you have a response to that?
Thank you, Mr. Chair. Thank you, JJ. I am in a tougher spot. I will be coming back every single right until we figure out how to collectively move forward. You know, I think that the homemaker part is I hear you, really challenging. And hearing those concerns from the community myself, the option that was put before me was to reduce all of it to 5. And again, that's still something we're considering. If the board wants me to pull that apart and bring that piece back in particular and just vote on the other pieces, I would offer that to you. I know you have a lot of other rules to consider. I just know I don't have the budget to agree to what you're asking me to agree to.
Thank you, Ms. Silva. Members of the board, any additional questions?
This is Amanda Trishlinsky. I'm gonna speak for myself as a freshman board member this year. I just don't feel like I know all the processes, but I feel, I guess, that I'm being asked to make a decision on something that I can't make a decision on, quite frankly, because I don't know all of the rigmarole of, like, you know, can we pull this piece out? Can the JBC come back to look at this again? There are additional rules that might come down the pipe and then therefore impact this. I'm feeling a little bit overwhelmed, to be perfectly honest, in making a decision on this right now. And so I just put that forward also because I feel that it is 11:23 and I'm a little bit concerned of how many more questions I can generate, but it's all because this is because of the enormity of this decision. So that's helpful, but
If I may, Mr. Chair.
Yes, please.
This is Rachel Intrican. I think the question on the table is, can we pull the homemaker piece from the rest of this rule? And the answer is yes, we can, as long as we make it clear. Am I correct? Yes. Yes.
Okay, so is there an appetite for that, for pulling the homemaker piece?
Forward from.
Yeah. How about online?
I would be open to voting on that rule while pulling out that homemaker piece to do additional work. Yes.
This is David. I concur.
Okay. Rachel, can you help us with the drafting of the revised motion for that? What that would look like?
I need to phone a friend.
Yep, absolutely. maybe this is a good time for a bio break. So let's go ahead and take a 5-minute bio break, everybody. Thank you very much. We'll be back at 11:30.
Hello, community. I would like to call out a point of order. I'm getting emails from the board of commissions that are not being presented to the board.
I apologize, Laura. This is Chris Sykes. Could you say that again?
I just received a letter from an email called Board Commissions Gov Office that is reaching out to each one of us during meeting. It has not been read into the meeting, and they are asking us to make decisions on a rule based on Governor Polis's advisement. However, this letter has not been read into public record and was sent to my personal email address in the middle of this meeting, and I have an open air concern with that. And I would immediately like somebody from the governor's office to explain this letter and read it into record.
It's about another issue that's not at this meeting.
Okay,
Not about something that we're considering at this meeting.
wonderful. Thank you.
You're right.
I didn't get that email.
Okay, right, it's here it is.
It just.
Oh, literally.
It's about the 340B that we're gonna, for the final, essentially.
So did the governor's office then send us stuff that has nothing to do with what we're doing? What is going on here, state of Colorado?
Deep breaths. Anyone else?
Laurel, I don't think any of the rest of us got what you got.
Actually, I did.
We
You
did.
did, yeah.
Yeah, we all got it.
Yeah, I received it. I see Chris Sykes' name on there as well. And I agree with you, Laura. It was very disconcerting to see that email in the middle of this board meeting, whether it applies to what we're talking about or not.
We have been given so much talk about how we are supposed to acknowledge open air, and then for the governor's office to come in and do exactly the opposite as a point of order. I want to make sure that this is on record, completely unacceptable.
Sorry, 11 minutes ago, yes. Did I get that?
I'll go forward.
Yeah, on the bottom.
Madam Chair,
She's saying that's still the last year.
Laura, we are having Rachel Intrican review the letter right now. For clarity.
Yeah.
Still coming. You know tomatoes is coming.
yeah, thank you so much. You're a gentleman and a scholar.
Madam Chair, this is Rachel Intrican. I am going to reach out to boards and commissions. I've never seen this happen before. And this rule isn't before the board today. It's not on today's agenda, so I will do some digging. Sorry for the confusion.
I appreciate you, Rachel. Thank you very much. And I am sorry to disrupt the meeting when I am not sharing it. Back to you, Tiny.
Thank you, Madam Chair. Appreciate it. All right. Are we good to move forward, everybody? All right. So coming back to Rule 1 before the group today. To recap where we're at, we're at the point where we're going to make a motion, and there was some discussion about revising that motion. I do believe there is a revised motion on the table. Who would like to read that revised motion or present that revised motion?
And to be clear, this is Rachel Intrican. I am handing Mr. Costello a list of all of the places where a homemaker shows up in the proposed rule.
Thank you, Rachel.
Trusting that this reflects the discussion.
Yes.
All right. JK, are you willing to make the revised motion?
I am.
Excellent. Do you need a few minutes to digest that?
Do I say this after this? Okay. I'm good.
All right.
And move the final adoption of document 1, MSB 25-02-25-A, revision to HCBS benefits and services requirements and community first choice, sections 8.7500 and 8.7600, incorporating the statement of basis and purpose and specific statutory authority records. And move that adoption of the rule with deletion of sections 8.7527.D.2, 8.7527.F.5, 8.7515.E.8, 8.7515.S.1.C, and 8.75 to 8.J.7.
So do I have a second?
This is Laura Carroll, happy to second.
Okay, thank you, Madam Chair. All in favor, say aye.
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 Any opposed? Do I have any abstentions? All right, the motion passes. All right, on to the initial approval agenda. Let me give you just a second. And actually, let's do department update first, if we can. Or no?
Sorry, this is Chris Sykes. Just given the hour,
Okay.
can we just
Yep.
work on the rules?
Perfect.
Thank you.
All right. So after further advisement, we're gonna move on to the initial approval, and we're gonna start with document 2. I have Mr. Russ Ziegler and Kelsey Leva.
Good morning. This is Russ. Can everyone hear me?
We can. Thank you. Thank you for being here, sir.
Wonderful. Thank you. I'll get started, and I just want to be respectful of everyone's time. So I'm going to talk pretty fast, but if you need me to slow down, just let me know. So good morning, Mr. Chair and board members. And my name is Russ Ziegler, and I'm a compliance and policy advisor in the administrative law and policy section of the department. I'm here to present the appeals process rule, MSB number 25-09-17-B. Rachel Entrekin, the department's legal division director, Christine Niernes, a department appeals officer, and Kelsey Leva, the department stakeholder specialist who worked on our outreach for this rule, are also co-presenting with me. So I will jump straight into the slide deck we have prepared for you. Next slide, please. So just went through the speakers. Next slide. Okay, this is a very straightforward and concise breakdown of the appeals process. We wanted to just give this as an overview before we jumped into the details. I'm going to gloss over it quite a bit, not because I want to leave anything out, but because we're going to jump into each one of these elements in more detail later. But I just want to give you a visual presentation of what this process looks like. So it begins with filing an appeal. Now this is they have 60 days. Members or applicants have 60 days from the date on the notice of their notice of action letter to file an appeal. That then goes to hearing and initial decision. So under both of those two processes, there is no change to those under this proposed rule. So after you file your appeal, there will be a hearing, and then there will be an initial decision issued. So from that point forward, that's where this rule comes into place. So after the initial decision is issued, members and applicants can then file exceptions to that. So under the proposed rule, we've made a couple of changes, and we'll go into more detail there. But essentially, an exception is a disagreement with the initial decision. And you can ask for this for a review of the initial decision based on filing exceptions with the department, the Office of Appeals. Going to the next section, again, we'll go in more detail later on, but just want to keep this moving forward. The final agency decision, now this is also being updated under the current rule. Right now, there is one track. So an initial decision is issued by the Office of Administrative Courts. And then the department will do a substantive review of that initial decision, whether or not there are exceptions filed. You'll see under the proposed rule there will now be 2 tracks. And again, we'll go into more detail about that moving forward, but that would be changed under the proposed rule. And then the last part, at least for the appeals process that you'll see in the rule before you, a member or applicant may file a motion for reconsideration of the final agency decision. We did make some changes to that to expand or to clarify what good cause for a motion for reconsideration would require to have the final agency decision reconsidered. But again, we'll get into that in more detail later on. So I'll keep moving forward. Next slide, please. Okay, this is our stakeholder engagement section. I will pass this part over to Kelsey Leva.
Thank you, Russ. Good morning, board members. I can still say good morning for a few minutes. I'm Kelsey Leva, and I'm happy to share with you about the stakeholder engagement journey that inspired the rule before you today. Next slide, please. So the push to simplify the process between initial decisions and final agency decisions came most recently from our community partners in the advocacy space. Once our team identified a way to implement that idea, we took the first step in gathering stakeholder input through a survey. Health First Colorado members represented 83% of our survey respondents. These survey results were very informative and inspired several revisions to the proposed rule. They also helped shape the design of the remaining stakeholder engagement process. Next, we published a draft of the proposed rule and a frequently asked questions document, and held a follow-up meeting with stakeholders to share the changes to the proposed rule and hear additional input. Throughout the rule design process, we also met with advocates who shared their expertise and helped shape the rule. So far, we've responded to 138 questions or comments from stakeholders, as you'll see outlined in the stakeholder feedback log. Our follow-up with stakeholders on this project included responding to 40 questions publicly in the frequently asked questions document, following up one-on-one to address private or sensitive concerns, and responding to questions and concerns in meetings. Next slide, please. I want to take a moment to highlight some changes in the proposed policy that you're going to hear about today that were informed by feedback from members, providers, advocates, and our community partners. We want to thank everyone, all the stakeholders who gave their time and expertise to help shape this rule. It is clearly stronger because of their efforts. So you'll see here on this slide that stakeholders helped us improve the proposed rule by adding the definition of good cause for failure to file exceptions timely, increasing the total time to file exceptions from 18 to 20 calendar days, adding a 45-day calendar extension from the original due date for filing exceptions for members and applicants when written transcripts are requested, and adding a description of the administrative review all initial decisions receive. You're going to hear more detail about these changes in the coming presentation. I also want to note that stakeholder input has informed our communications plan in several really important ways, should the proposed rule move forward. And lastly, I want to call out one area of feedback where we remain outside of consensus with stakeholders, and that is regarding concerns that the proposed rule bypasses statutorily mandated reviews for initial decisions. I'm going to hand off the presentation now to Rachel Entrekin so she can speak more on the department's perspective on this and why we remain at an impasse. Thank you.
Thanks, Kelsey. Thank you, Mr. Chairperson. My name is Rachel Entrekin. I am the Legal Division Director for Healthcare Policy and Financing. And I want to reiterate what Russ said earlier. This is a really important rule for us to make, and it's important now, and I will get into that a little bit later. So we've had a member and applicant appeal rule for a very long time. And we have the same structure to it that we had since before the expansion of Medicaid in 2014. At the time, it was an adequate process. We had a small and nimble Office of Appeals within the department that issued final agency decisions, which is essentially the final step in an appeal process. And that appeal is not final until that final agency decision is issued. And that's what we're trying to address here, is how do we compress some of the timeline growth that we're seeing to make sure that people are getting finality in their appeals in a timely way. I want to talk a little bit about that one area where we have not come to consensus with all of our stakeholders. We have with some, but there are outstanding questions, and those are the questions I want to address for you today, because you may have seen them in the stakeholder log, and you may hear about them today in testimony. So there are a couple of different statutes that govern the way that member and applicant appeals in Medicaid play out. It's pretty prescriptive. There's the Administrative Procedure Act that controls Medicaid appeals and all other administrative appeals in the state. And then there's also Title 25.5, which is HCPF's set of statutes in the Colorado Revised Statutes. In both of those areas, in the Administrative Procedure Act, which I might slip and call APA, that's what I'm referring to, in the APA and in HCPF statute, there is explicit permission to HCPF to run a rulemaking, which is what we're doing today, to implement an alternative review process. Yeah, I'm so sorry. Can we have the next slide, please? I'm going off of my slides instead of what's on the screen. My apologies, everybody. So under Colorado statute, we can have a dual track, which is what we're proposing today for appeals. For appeals that have exceptions filed, and I want to be really clear when we're talking about exceptions in this space, it's different from the exceptions that Bonnie was talking about this morning. So if we're talking about exceptions to soft caps, that is a service limit. When we're talking about exceptions in the appeals sphere, we are talking about when someone raises their hand after they get an initial decision following their appeal hearing. They say, I don't like what the initial decision says. I want someone else to review this and see if the administrative law judge who heard my appeal hearing got it right or got it wrong. So I'm going to refer to those as appeals exceptions today. It is as simple as writing a list of things that you disagree with, writing a letter, sending it in for review. So anyway, Colorado statute explicitly does permit HCPF to implement an alternative review process where there are unchallenged decisions, meaning nobody filed those appeals exceptions. And that authority allows HCPF to propose a rule, which is what we're doing today, that can streamline the appeal review process where there are initial decisions issued from the Office of Administrative Courts, i.e. the entity that actually hears the appeal hearing, takes the questions and testimony, and then writes up an initial decision. So what we want to make sure that we're doing is where there are unchallenged initial decisions, meaning no one has raised their hand to say, I disagree with the initial decision, that we can provide a parallel process to really improve timelines and provide clear answers to people and reduce unnecessary spending through continuation of benefits that can happen for individuals who appeal a reduction or loss of benefits when they already receive them. And we'll go into that a little bit more detail in a minute. Can I get the next slide, please? Okay, so I want to start with the Medicaid statute in state law. So if exceptions are filed, then the department is if appeal exceptions are filed, then the department is required to issue a final agency decision, a written decision saying whether or not the initial decision was right or wrong. And that substantive review is performed by the HCPF Office of Appeals in all of those cases where exceptions are filed. Can I get the next slide, please? But our HCPF statute goes on to say that if appeal exceptions are not filed, it says in the absence of any exception filed pursuant to section 24.4105, that's the Administrative Procedure Act, then the executive director of HCPF or their designee, meaning our Office of Appeals, can review the initial decision in accordance with a procedure adopted by the state board. That's you. And so that procedure is what we are trying to create today. Next slide, please. So going to the Administrative Procedure Act, which is what's cited in the last slide, what the Administrative Procedure Act also says, it essentially mirrors the Medicaid statute, in the absence of any appeal exceptions that are filed, then healthcare policy and financing is required to review the initial decision in accordance with a procedure adopted by the Medical Services Board pursuant to Medicaid law. So that is what we are proposing today, and that's what you've seen in your packet of materials. Next slide, please. So the purpose of this rule is sort of threefold. It's really to establish a procedure for reviewing initial decisions where no one has raised their hand and said, I disagree with the initial decision. It is a way to streamline that process and speed it up to make sure that there's finality for members and applicants who have appealed a denial or reduction in services. It would replace the substantive review that all initial decisions are currently receiving, regardless of whether or not someone has disagreed with that decision. And what we're seeing is that we end up with a backlog of appeal decisions, including all of those initial decisions where no one has said, I disagree. And that backlog is getting bigger and bigger, no matter how much we try to kind of keep up with it. Under federal law, we're required to finish all of our appeals within 90 days from the time that someone asks for the appeal until that final agency decision is issued. We're not meeting that in a lot of cases, and that's important for several reasons why we'll talk about towards the end of the presentation. But what we're looking for is a process that still protects our members and applicants' due process rights, that still satisfies state and federal law around what appeals need to look like for Medicaid, and also how to do it in a way that is more efficient and gets people answers faster while still preserving limited state dollars. Next slide, please. Okay, I'm going to pass it back to Russ, who's going to talk about the specific changes to rule. Thanks, Russ.
Thank you. This is Russ Ziegler again, and I think I was invisible before when I talked to you, so I apologize for that. Hopefully I'm on screen now. I've got the block uncovered. So next slide, please. These are the proposed appeal process changes in the rule before you now. So I'm going to go through those steps that we talked about before. I'm going to kind of go through each one of them individually. The first slide will say what's the case under the current rule, and then the next slide will say what's changing for those specific aspects of the appeal process. So the first two you can see are the actual appeal. So again, that has to be made within 60 calendar days of the date of the notice of action letter. And then once that appeal is made, a hearing is held by the Office of Administrative Courts that issues an initial decision. Next slide, please. So under the proposed rule, those two things are not changing. Those will remain the same under this proposed rule if it moves forward. Next slide, please. Okay, parts 3 and 4. So under the current rule, and Rachel already spoke to this, but again, I think the repetition may be helpful because this is a kind of complicated process. You may not be familiar with it. So after the Office of Administrative Courts issues that initial decision, a party may file exceptions. Again, those are appeal exceptions. To ask for further review. Exceptions under the current rule must be filed within 18 calendar days of the mailing of the initial decision. And we wanted to really highlight that an exception can be as simple as an email to the department stating a member applicant's disagreement with the initial decision. So that's the exceptions process. So under the current rule and process, the final agency decision, after reviewing the administrative law judge's initial decision, any written exceptions and any responses from the other side, the department's Office of Appeals will send their final agency decision. So they will review that initial decision, take all of that information into consideration, including any exceptions, and then they will issue the department's final agency decision. And that can take form in three ways. So it can confirm the initial decision, it can overturn the initial decision, or it can send the appeal back to the Office of Administrative Courts to hold another hearing. So that's the current process. Next slide, please. So this is under the proposed rule. So under this rule that we're proposing now, we are adding additional time. So we wanted to, and that's a lot of that is in response to stakeholder comments about mailing. Especially for rural members that may, that process can take longer. So we added 2 additional days for mailing time. So now under this rule, the exceptions must be filed within 20 calendar days. We also added a 45 calendar day extension from the original due date for filing exceptions for members or applicants when written transcripts are requested. So if someone says, you know, I want to have a transcript of the of the hearing so that I can study it closer, they will not have to ask for an extension. They'll just get an automatic 45 calendar day extension to do that review and receive the transcripts. Under the final agency decision, and again, we'll go into more detail here. Under the current process, like I said, all initial decisions get that substantive review by the department. And again, that will continue, as Rachel indicated, if there is any exception filed to appeal exception filed in regard to the initial decision. So if anyone disagrees with the initial decision. However, under this rule, and again, we'll go into more detail later, so we won't go to all of it here. If no exceptions are filed, that initial decision will automatically convert into a final agency decision. And I'll go into more detail as far as how that process would move forward under the proposed rule in later slides. Next slide, please. So after all of that has happened, there is one more bite at the apple that member and applicants have, and that's called a motion for reconsideration. So if exceptions are not filed and the initial decision becomes the final agency decision, a member applicant may still file a motion for reconsideration by explaining a good cause reason for missing the exceptions deadline. The current time frame for that is 15 calendar days. And we currently do not have a definition for what is good cause. So that's the current rule. Please move to the next slide. So under the proposed rule, we actually don't have that in this slide here, but you'll see in your rule packet on the last page of the rule, we're changing that deadline. So after the final agency decision is issued, it will be 20 days. So we're adding 5 days to that time frame. We also added, and this was in the direct response to stakeholder comments, which we actually thought were extremely helpful. We're adding a definition for good cause, so that when members look at that and say, hey, I might want to file a motion for reconsideration, they have a good example of what exactly good cause is. And I've transcribed the definition you'll see in the rule before you directly into this slide. So good cause shall mean circumstances beyond the control of the member, including not limited to medical emergencies or hospitalization, a member who has a disability or other medical conditions requiring additional time and or assistance. And this last part, again, was also in response to stakeholder comments. So, or a statement that the party did not receive the initial decision prior to the deadline for exceptions. So if they're saying we had a mailing issue or whatever happened, they can make a good cause reason for having that that motion for reconsideration would be they did not receive the initial decision prior to the deadline for filing exceptions. Next slide, please. So we just want to give a quick rundown of, so what doesn't change on the proposed rule? So member applicants or the representatives will continue to have the same rights. So they still have the right to request an appeal. There will still be a right for the continuation of services and benefits during an appeal when eligible. Also to have a hearing in front of a judge during which they can present evidence and arguments. That would be that hearing process of the Office of Administrative Courts. To receive a written initial decision after that hearing. To raise disagreements with an initial decision. Again, that's that appeals exception process. And then finally, to seek further review through exceptions as they do under the current process. Next slide, please. So again, staying on what doesn't change under the proposed rule, the process that begins when a member, applicant, or representative files exceptions would not change. So if exceptions are filed, the Department's Office of Appeals would continue to conduct a full substantive review and issue a separate final agency decision, just as it does today. Members, applicants, or the representative's ability to challenge an initial decision and seek further review remains unchanged. Next slide, please. Okay, so what does change under the proposed rule? So the review process for initial decisions would change. So we've added a new type of review to the rule you'll see before you. So all cases will receive an administrative review. So in a case where no party has filed appeal exceptions disagreeing with the initial decision, within the time frame for filing those exceptions, the initial decision will automatically become the final agency decision after 30 days from the day the initial decision was mailed, unless the case is selected for substantive review, in which case the department would mail a notification of its decision to conduct a substantive review within 30 days of the mailing of the initial decision. So I know that's a mouthful, but essentially what we're saying is if no one disagrees with that initial decision, we will then do an administrative review, and we'll go into more detail of what that looks like. And then it will be on the department's discretion to say, well, okay, we're not going to review this more substantively because we haven't identified any issues, and we'll allow this to become the final agency decision. However, if issues are identified during that administrative review, the department still has the option to say, you know what, we're still going to do a substantive review of this, and then we will mail a notification to the applicant or member saying, even though you did not file exceptions, we are still going to conduct a substantive review for this specific appeal. And in that case, a separate final agency decision will be issued and mailed to the parties just as it would be under the current process. Next slide, please. So what is this administrative review? And I really want to give a shout out to our stakeholders. We didn't originally have this defined in the rule, and they really, emphasized that this needs to be explained in the rule. So we took that feedback and we updated the rule to include an explanation of what an administrative review is. So, it is an internal step by the Department's Office of Appeals that is used to review an initial decision, which again is the administrative law's judge's decision on the appeal. After the initial decision is issued, in any case where exceptions are not filed. So that's that second track. So during this review, initial decisions will be checked to ensure they include the required components. These are statutory requirements, so findings of fact, conclusions of law, and an order granting or denying what the member or applicant is asking for in their appeal. The initial decision will also be reviewed for any legal errors. As part of this process, the Department's Office of Appeals will continue to collect information about appeal outcomes. Next slide, please. So we received additional stakeholder comment after we did our, just in the last week or two. And after internal discussion, we decided that some of it really made a good argument that we should add an additional clarification of what the administrative review will include. So in response to those comments, so this is not in the rule before you because we just made this decision recently and we didn't want to give you a whole new package. So we decided we would do it right here during the presentation. So if you look at your rule packet, and I believe it's on page 2 of the rule before you. So it's section 8.0579G. You'll see that that's where we define administrative review. And again, it mirrors what I just said. So we're reviewing to ensure they include findings of fact, conclusions of law, and an order granting or denying relief. And we're proposing to add a subsection to that that will say administrative review includes reviewing the initial decision for the proper application of federal and state law, regulations, and policies. So that kind of drills down rather than just speaking generically to conclusions of law. We're saying we're actually reviewing to make sure that the federal and state law and regulations and policies were properly applied. So that's another layer of the administrative review. Next slide, please. Okay, so what's a substantive review? So this is an additional thorough review, and actually this second part of this sentence here, I would actually revise. Whenever we do a substantive review, it will always result in a separate final agency decision. And again, with those two tracks that we're talking about, when appeal exceptions are filed, it will always receive a final agency decision. And under the second track, where there's no disagreement with the initial decision, we'll do that administrative review. And then if the department elects to do a substantive review, in all cases, a notification will be sent to the member applicant and a final agency decision will be issued in mail. So this is the process that will differ from the current review practice. Currently, the Department's Office of Appeals conducts a detailed substantive review of every case, even when no one has filed appeal exceptions. In other words, no one has disagreed with the initial decision. Next slide, please. Okay, so we just want to give a quick rundown of what a substantive review looks like. So when will it be conducted? Excuse me. So whenever exceptions, requests for transcripts, or requests for extension of time to file exceptions are filed, those will always receive a substantive review. Also, when initial decisions do not contain findings of fact, conclusions of law, and an order granting or denying what the member or applicant is asking for in their appeal. So if we identify that as part of the administrative review, that will also always receive we will elect to do a substantive review and a final agency decision. And then what I was referring to before, when legal errors are identified during the administrative review of the initial decision, there will still be a substantive review, even if exceptions are not filed. Next slide, please. Okay, and I just want to do one more slide, kind of summarizing more procedural updates that the proposed rule changes. So under the proposed rule, like I said, we added that definition of good cause. Which again will includes if a applicant or member did not receive the mailing in time to file their exceptions. It also automatically grants an extension of 45 calendar day extension of time when a member or applicant requests transcripts, and it increases the mail time from 3 to 5 calendar days. And like I said, like I was indicating to before, we also added a full 5 calendar days to the time to file a motion for reconsideration. So overall, it relaxes the rules when a party does not timely file exceptions. In other words, does not indicate their disagreement with the initial decision. And it simplifies the process for members and applicants when they want a written transcript. Next slide, please. So I will now hand this back over to Rachel Entricken.
Thanks, Russ. Rachel Entricken here with the department. I wanted to give a little bit more context about why we are asking the board to consider the proposed rule before you now. So if we could move on to the next slide. Thank you. So I just want to reiterate, one of the reasons why we're proposing this rule now is simply the growth in the number of appeals that we're seeing filed. Appeals are filed in one of two situations, and I'm realizing we probably should have started with this as our beginning sentence. There are two kinds of appeals. There are eligibility appeals for people who are either initially coming on to Medicaid. They fill out an application, either it is granted or denied. If it's denied, anyone whose application is denied is entitled to a hearing if they want one. And that starts the appeal process. That is also true for individuals who are already on Medicaid and going through their annual renewal. For some people, that's about to change to a twice yearly renewal under the changes in HR 1. So those are eligibility appeals, either for renewals or for initial applications. Then there are also benefit appeals. Individuals who are asking for services that go through the prior authorization process. If that prior authorization is denied, they are sent a notice, and that notice triggers the right to an appeal. So types of benefits that go through the prior authorization process are benefits like long-term home health, private duty nursing, durable medical equipment, imaging, those kinds of services. And so under federal law, from the day that someone asks for an appeal, once they've received that notice, to the day a final agency decision is issued, we are allowed, state Medicaid agencies are allowed 90 days to complete that entire process. There are some exceptions to that. If a member needs more time or an applicant needs more time to gather documents, so they ask that their hearing be rescheduled. If they're sick on the day of the hearing, they can do the same thing. Those kinds of extensions don't count against the state Medicaid agency. But all other hearings over 90 days, we report to CMS. And HCPF isn't meeting the deadline due to staffing shortages and process delays. We're working on the staffing shortages piece, which is hard during a budget crisis, but we are doubling the number of individuals that we have working in our Office of Appeals from 3 to 6. But that's not going to fix this issue entirely. So let's move on to the next slide, please. So the delays that we see in the appeals that are over 90 days kind of take two forms in terms of negative outcomes or impacts. One is for people who are denied Health First Colorado eligibility or benefits, and they are not currently receiving those services. When they appeal, they're still not going to get those services until their appeal is final. And so the length of time that it takes to get through the entire appeal to the time a final agency decision is issued, they're going to have to wait for those benefits and services. And that really lengthens the amount of time that people can go without really necessary care. The other issue is because cases are not finalized for a long time under the current process, these can lead to really significant increases in costs related to benefits that are provided to people who appeal but may no longer qualify. Right, there's been a medical necessity determination in the utilization management process that says, hey, Rachel Entrekin is no longer eligible for X service. If I ask for an appeal timely and I ask for continuation of benefits, I can continue to receive those services for the entire length of the appeal until the final agency decision is issued. And so that really impacts our ability to ensure that these limited taxpayer dollars that we talk a lot about are directed to individuals who need the care most and not individuals who may not need it any longer. And so by going that second track for cases where no one has disagreed with an initial decision, we reach finality sooner. And that helps people who either aren't receiving benefits to get finality sooner. And it also helps the department really watch out for those scarce state dollars when continuation of benefits can be quite costly. Next slide, please. And I did want to just use this. I know data can be helpful sometimes. So I wanted to sort of put this in real numbers for you all. So the Office of Appeals in the last state fiscal year, so state fiscal year 2024-2025, ending June 30th, 2025, reviewed 2,565 initial decisions in cases where nobody filed appeal exceptions. Some of those reviews are very, very fast. For example, if they're an initial decision dismissing an appeal because the parties reached an agreement. Those can happen less than an hour. Some of these exceptions take 40 or more hours to complete because they may include very voluminous medical records, novel issues of law or fact. There could be transcripts that they have to read through. So it can take a really long time to get through even just one final agency decision. So when the Office of Appeals reviewed these 2,565 initial decisions without exceptions, only 11 of them changed in the final agency decision full substantive review. 7 of those cases had final agency decisions that changed the initial decision. 2 of those were decided, went from a decision in favor of the department to a decision in favor of the member applicant. 5 of those 7 changed from a decision in favor of the member applicant to a decision in favor of the department. And then 4 cases were remanded to the Office of Administrative Court for a new hearing, typically because there were evidentiary issues, or there's also been scenarios where for some reason the automatic recording system didn't work, and so there was no record that was made. And so we're looking at only 11 changes out of 2,565. We are aiming for the best possible solution. And unfortunately, it can't be a perfect solution. So is it possible that a very small number of cases may have had a different outcome with a substantive review? Yes, it's possible. But we think the data really supports the idea that if people are concerned about their initial decision, they can raise their hand, send that email, they can send that letter, and get that substantive review. But otherwise, having an automatic transition from an initial decision to a final agency decision really makes sense in terms of trying to get that finality as soon as possible for individuals and for the department's budget. Next slide, please. Okay. That is the end of our presentation. We are more than happy to answer questions from the board.
Great, thank you. Rachel? I just want to start out real quick by acknowledging once again just Russ's and his team's ability to just do an incredible job and knock it out of the park every time with their presentations, with their stakeholder engagement. I mean, I can't say it enough. This is the standard that, I mean, like it would go so far if everybody could present this way, and getting feedback from you guys first and bringing you in and involving you in that process. I think, yes, it takes time, but I think it's really helpful. So thank you guys. Thank you very much. With that, I open up to the board. Is there any questions from the board? JK?
Hi, JK Costello. Quick question. The initial decision, I get that that is mailed, snail mailed to the person. Is it also emailed to them?
This is Rachel Entrekin. It is not also emailed to them. So under state law, under the Administrative Procedure Act, we are required to snail mail it to them. There is not an option to email it. And with only 3 staff available to do anything related to mail or email, we can't do both. I think there is a statute, or sorry, there is a bill before the General Assembly right now that is potentially going to change from only mail to either mail or email. So, but that's a separate process that we have not been included in.
Thank you, Rachel. JK, did that answer your?
It does. I just noted that they can request an exception via email. So it stands to reason the whole process could be much shorter. But I get that it's out of your hands.
Anything else, JK? Rachel, thank you. Dr. Kennard.
Quick question here, and unfair as usual for me. Is there an expectation there'll be substantially more appeals in the coming years? And is part of this, I assume one of your whys for this is that the faucet is not going to get turned off. It's going to be.
Rachel Entrekin for the department. Dr. Kennard, thank you. That is absolutely true. I sort of mentioned it in passing. We have somewhere between 150,000 and 300,000 people who will be impacted by some part of the changes brought about by HR 1. Those changes go into effect starting in October. Any individual who's impacted by work requirements, also known as community engagement, or by the twice annual renewals instead of once a year renewals, will have the opportunity for an appeal. So on the eligibility side, we will see more eligibility appeals, not fewer. And the same is true. One of the things that we are really digging deep to do as a department is make sure that people who are getting services really need them. And so anytime we add a service into our utilization management framework, meaning there's a prior authorization with a medical necessity determination. If there's ever a partial or complete denial of those services, individuals are eligible to file an appeal as well and get noticed, so that they know that that is their right. We want that to happen. That is absolutely an important part. Medicaid is an entitlement. People have constitutional due process rights. And we want to make sure that we are doing the very best we can to process those appeals timely when they come.
Thank you, Rachel. JK or Dr. Kennard, sorry. Any?
All good, thank you.
Dr. Jaslinski.
Hi, this is Dr. Amanda Jaslinski. So, question: are you worried that this kind of automatic approval process, which sounds like so that would be new, I guess my question is, how would you be reviewing this process and its impact after implementation to make sure that your 11 out of 2,000 whatever it is accurate, that you're not missing a bunch of, I don't know, situations that should have received appropriate review?
Yeah. Thank you for that question, Dr. Jaslinski. Rachel Entrekin for the department. I guess I would say 3 things. One is we absolutely are going to be reviewing, the administrative review is going to catch a lot of what we would be concerned about. We want to make sure that every initial decision contains all of the required components. And so those are the findings of fact, conclusions of law, and an order on the relief requested. It is also looking out for any legal errors. Where there could be issues would be if there were errors of fact, right? Like the administrative law judge maybe didn't put into the initial decision important evidence. That's where we're really relying on our members and applicants and responsible parties to alert us to that fact. And the initial decision will go out with sufficient time for people to do that.
Thank you. Does that answer your question?
Yes. Thank you.
How about online? Do any of my board members online have any questions?
This is David. I do not.
I'm good, thank you.
Thank you. All right. Do we have any public testimony on this?
This is Chris Sykes. We do. We have Bryce Rafferty signed up.
Excellent. Mr. Rafferty, if you'd make your way up here. Thanks again for hanging out with us through this long day.
This myself right here again, if that's all right. Thank you again, Member Chair, members of the board. My name is Bryce Rafferty, representing CCDC. Earlier drafts with this rule raised real concerns about timeliness, notice, and whether members could realistically be able to navigate the review options after receiving an initial decision. But through continued engagement, our initial concerns have been meaningfully addressed through iterative drafting and collaboration. What is important about this rule, as you've heard, is that it focuses on a very specific and very important point in the appeals process, and that's what happens after the ALJ issues the initial decision. At that stage, members need to know what their options are, how to file exceptions, when they must act, and what happens if they don't. For people with disabilities, those are not small procedural details. They're the difference between having a meaningful opportunity for review and losing rights through confusion or silence. And while reasonable minds can differ on statutory interpretation, CCDC believes that given the constraints and circumstances we are all facing here, that the rule is now stronger because it much more clearly addresses the path from initial decision to final agency action. Still, its success will depend on whether members can actually understand and use that process in practice. They need notices that clearly explain what an initial decision is, what an exception is, what an exception must be filed, and what consequences are if they will have if they do nothing. They also need accommodations, plain language materials, so the process is successful, communication, and accessibility for people with behavioral or comprehensive comprehension disability. So we support the rule and progress that has been made, but again, implementation is where the risk remains. Members need to understand what their rights are, notices need to be clear and accessible, case managers and providers need consistent guidance, and the department will need to monitor whether the streamlined appeals process is actually improving access or inadvertently creating new barriers. And I would just, again, like to thank the department for its continued collaboration with us here at CCDC and with other stakeholders. That has resulted in many things, including various online resources, an insert that will be included with every initial decision that will have a dual track. What happens if I take action? What happens if I don't take action?
Sorry to cut you off, Mr. Rafferty. I do appreciate your time. Does anyone from the board have any questions for Mr. Rafferty while he's here? Excellent. Well, thank you very much. All right, Mr. Sykes, do we have anyone else for testimony today?
This is Chris Sykes. We have Katie Wallet.
Katie, are you there?
Can you all hear me?
We can hear you well. Thank you for being here.
Good morning, Chair and board members. I am Katie Wallet from the Colorado Center on Law and Policy. I am testifying to highlight some of the information I provided in a letter sent to you earlier this week. Current law distinguishes HCPF from all other agencies besides CDHS in requiring the department to review each initial decision from the Office of Administrative Courts. The law reflects clear legislative intent to safeguard individuals whose health and survival depend on continued access to medical benefits. HCPF does not have the power to change this statutory requirement via rulemaking. The additional review required in Colorado law reflects the fact that essential public benefits like Medicaid require greater procedural safeguards to protect them. This proposed rule removes a level of review by a judge, stripping one of those safeguards. And when CCLP has spoken with community members and conducted Know Your Rights presentations about filing appeals, we have learned that most Medicaid members do not understand the exceptions process and very few utilize it. We also know that most Medicaid recipients pursue appeals without counsel or any other assistance and cannot depend on the mail to be reliable or quick. This proposed rule, while well-intentioned, is improper. Medicaid members have a property interest in their benefits, and that right has been scaffolded with an explicit requirement mandated by the legislature that HCPF performs a subsequent review. While HCPF may establish the specifics of that review with the process adopted by this board, the process may not be in contradiction of law. Replacing the current substantial review with the baseline review process that is already required of all agencies is an illogical interpretation and would gut the intent of the statute. More importantly, this proposed rule would lower Office of Appeals caseloads at the expense of Medicaid members, the very people who need that secondary substantive review. Whether that is 10 or 10,000 members, they are all entitled to the protections of due process enshrined in state law. HCPF doesn't need to change the rules this way. They need to hire more judges in the Office of Appeals, which would reflect their investment in safeguarding due process. CCLP respectfully but strongly urges the board to reject this proposed rule. I'm happy to answer any questions. Thank you for your time and attention.
Thanks, Ms. Wallet. JK, did you have a comment? Oh, sorry. Did anyone else on the board have a comment or a question for Ms. Wallet? All right. Thanks again for your time. We appreciate you. Chris, do we have anyone else for testimony on this one?
This is Chris Sykes. We do. We have Megan Bowser.
Excellent. Ms. Bowser, good to hear from you again. How are you doing?
All right. Thank you for your time.
Absolutely. You have 2 minutes, my friend. Please commence.
Thanks. My name is Megan Bowser again. I'm the Executive Director for Family Voices still. I want to speak regarding concerns of this rule unless stronger protections are added for appellants who never actually received their initial decision. My concern is not theoretical. In one appeal we participated in, the hearing took place in September of 2025, yet we started 2026 still without an initial decision. After repeated status checks in March 2026, we were finally sent an electronic courtesy copy of an initial decision that had been issued a month earlier. Neither our organization nor the family had received the mailed copy. Another appeal we participated in that took place in December 2025, we still have not received an initial decision on. That's exactly the problem. This draft assumes that people will know when to act, but families and advocates often do not know when a decision was issued at all. The proposed reconsideration option does not fix that if the clock is already running before the member ever receives that decision. When some decisions arrive in less than a month and other it takes 5 months or more, there's no reasonable way for families to know when they should start escalating a missed decision. That creates a real risk that people lose rights through no fault of their own. Mailed notice is required by statute, but the Postal Service is notoriously unreliable, so the practical fix is redundancy. Initial decisions should be sent both by mail and email or through another trackable secondary method before the final decision timelines move forward. I acknowledge that doing so would add work to the department, but maintain that it is their responsibility to ensure members are appropriately informed. Thank you.
Thank you, Ms. Bowser. Does anybody have any questions or comments for Ms. Bowser? Again, thank you very much for your time. We appreciate you. Mr. Sykes, do we have anyone else?
This is Chris Sykes. We have Ginny Arrington.
Miss Arrington, are you there?
Hello.
Hello. Thank you for being here. You have 2 minutes. Please start when you are ready.
My name is Ginny Arrington. As you know, I'm a parent to a medically complex child who requires skilled care and medically necessary care. I want to highlight what Megan Bowser just said, is that appeals don't always come through. I would also like to highlight that delays could put my child at risk without guaranteed continuation of care. I want to address accountability when case managers are very hard to reach in my county. And when they do not act, we lose very important, consistent care. This is not optional. This is not easily replaced. There is no one that can come in, even though we have tried. I ask that there be clear and concise ways for communication and accountability for all parties. Thank you.
Thank you, Ms. Arrington. Does anyone in the board have any questions or comments for Ms. Arrington? Seeing none. Mr. Sykes, do we have anyone else slated for testimony?
This is Chris Sykes. We have Victoria Moore.
Okay, Miss Moore, did I say that right?
It's Mal.
What's it? Yep. Mal. Okay, sorry about that. Please go ahead.
Can you guys hear me?
We can. Thank you very much.
This time I'm coming to you as Victoria Mal, the founder of Impacted Caregivers of Colorado. I speak on this one as an advocate. My group is specifically to educate, inform, and rally caregivers in the state of Colorado. I have ran this group for 4 years, and I can tell you that every single day I get new people that don't know what a CES waiver is, a CEF waiver is, or CFC. They don't know anything. And then if you have a case management agency, I won't mention names, that is not responding in time, that is not getting documentation in time, that's not following through in time, and these parents have no idea what their steps are for advocacy or what avenues they have, they end up just giving up. And I cannot begin to tell you, and I know that there's several people in that room that can confer with me, how many times we have spent hours and hours a day trying to help educate a parent so they could just even get their documents submitted for an IDD. So to expect these families to understand and just get what this process is going to be without the additional help from advocacy, case management, and other people that are out here that try to support and guide these families, these appeals are only going to work because these families aren't going to fight them because they don't know how. So I'm asking that, just like Bryce said, before you put this forward, make sure that there's an avenue of education for these families so that they can be well informed and prepared for going through the appeal process in the first place. That's all.
Thank you very much, Ms. Mal. Any questions from the group, from the board? Right. Victoria, thank you very much for your time. We appreciate you on both counts today. Mr. Sykes, do we have anyone else slated for testimony on this?
This is Chris Sykes. We do not have anybody else signed up for testimony.
Okay, thank you very much. Do we have Mr. Ziegler, I believe?
Yes.
Do you have any response to the testimony given today?
Yes, again, this is Mr. Russ Ziegler for the department. I would like to respond to that thematically, and then I'll pass it along to some of my other co-presenters to add anything that I may have missed. But I would like to just first thank Mr. Rafferty and CCDC for their engagement with the department on this rule. It was extremely helpful, and all of our stakeholders, CCLP, everyone involved. Second, I'd like to address the statement about the statutory authority. I think the department is just at an impasse with this. We have a different interpretation. Again, I would point back to that language that Rachel discussed about the statutory authority, where there is a two-track approach in the statutes. It's very clear when exceptions are filed that we have to do a full substantive review. But there is a second track, and that's if there is no disagreement with the initial decision and no exceptions are filed, we have the authority to come to this board and say, this is a procedure that we think is appropriate to address those appeals that do not have disagreements with them. So this is that procedure. And this is the board tasked by the statute to that we have to bring that procedure to for voting. So that's what we're doing here. So I don't know if we're going to come to complete agreement with CCLP on their interpretation of that. We have brought that to the Attorney General's office as well, and to get their input. And we had we were in accord with them on their interpretation that was in alignment with ours. So I don't think we're going to come to complete agreement on that. Second, I'd like to point to the mailing and process times, which we definitely we really want to be cognizant of and respectful about, because we don't control the mail, and we want to provide as many flexibilities and time as possible. And we did address that in this rule. We increased the mailing time specifically for filing exceptions by 2 days. That extends the time to file exceptions from 18 to 20 days. And again, I really want to go back to the second bite of the apple here. So let's talk about a situation where the exceptions were not filed for the initial decision, that converts to a final agency decision if the department does not elect to do that substantive review. In that case, after the final agency decision, after the initial decision converts to the final agency decision after 30 days, a member applicant has an additional 20 days now to say, wait a minute, I didn't receive the mailing, or there was a reason out of my control that I was not able to file exception. So I'm asking for reconsideration. And so that option is still available. And again, going back to our stakeholders, which we always appreciated and really have refined this rule and refined our process in a very helpful way. We've got very strong feedback about the insert with the initial decision. So that insert will explain in detail, what are your options here? If you disagree, what should you do? If you don't disagree, this is what will happen if you don't file exceptions. So really, the process hopefully will address a lot of the concerns about mailing times or miscommunications. And we also discussed this, and Christine Niernes, one of our appeals officers, on the line, and I'll let her address this in more detail if she would like to. But we brought those concerns to her, and she said, really, we are always available if there is confusion, and if someone wants to know, like, hey, is there going to be a substantive review? Like, what's going on with my appeal? They can always contact the Office of Appeals directly about their appeal. And she actually recommended come directly to us rather than going directly to the Office of Administrative Courts. And again, if Christine, you need to clarify any of that, please do so. I am not an appeals officer, so I don't want to act like I'm the expert in that situation. Moving on to additional concerns that were raised as far as hiring more judges, we're actually in the process of doing that. And I want to go back to something that Ms. Entrican indicated, that, and Dr. Kennard actually raised a very cogent issue with, even with the addition of more appeals officers, with HR 1 and additional new requirements coming down the line, we're expecting more and more appeals. So those backlogs are going to continue. And this is a double-edged sword. While we acknowledge the concerns that stakeholders have raised about this streamlined appeals process, there is the other side of that, where if someone is waiting to receive benefits and they don't receive those benefits until they get a final agency decision. Well, as our backlog gets greater and greater, if we don't address that issue through a rule like this, that can impact those people. They will be waiting longer and longer. And also on the other side of that is the department could be paying for services that people don't qualify for a very long time. And in our current budgetary situation, that has real impact. So I wanted to address that specifically. Let me see if there's I'm trying to think if there's any additional themes that we wanted to respond to in the comments, specifically about emailing. I'm going to defer to Christine Niernes about, if we can email, what that would imply, what would be required of the department to do that, and if we have the resources right now to do that. And I'll let Christine speak to that. I hope I covered all of the main themes of the comments. I'm racking my brain right now. So I will stop talking and defer to either Rachel Entrican, or Christine Nirnez to kind of add on to anything that I've said here. Thank you.
Excellent. Thank you, Mr. Ziegler. Rachel or Kelsey, do you have anything?
This is Rachel Intrican for the department. I did just want to say we're hearing loud and clear about the email from both members and from the board. We're going to take that back and talk about it internally. It would be a big lift, but we also understand the importance. The one other thing that I was just going to say, one thing that came through loud and clear from in my conversations with Bryce, in conversation with CCLP and Colorado Legal Services, and what I heard today from Megan, Jeannie, and Victoria is the importance of very clear instructions about how people engage in the appeals process and what happens if a member files appeal exceptions or does not. So the insert that that Russ talked about is something that we've talked about in detail in terms of what goes into it. We're going to create an infographic, one of those little if-then pictures for folks to understand, if yes, I file exceptions, or if no, I don't, what happens next. We have a website that has very clear plain language instructions in writing. We also have 2 videos explaining eligibility and benefit appeals in plain language. Both of those are on hold right now. We've taken them down because of a change after the public health emergency and pending the board's action on this rule. And it'll be updated accordingly depending on the board's decision whether or not to adopt this rule. So I just wanted to add that as well.
Thank you very much. Yes, sorry, Dr. Jaslinski.
So thank you. This is Dr. Jaslinski. I just want to say for the record, I really appreciate the need for this. I can only imagine the administrative burden that is currently existing, and it sounds like, and will get worse, and it sounds like it's currently not a tenable situation. And I really appreciate the testimony of everyone who came forward today on this, because the Medicaid process of getting just standard Medicaid and re-enrolling is already kind of a mess. Like many people fall off. They don't get the letters that or they don't know what to do with them. They aren't sure how to reapply. I have so many patients that I take care of who are losing their benefits and having to re-enroll in their benefits, and their PCP is ascribed to the wrong type, and they have to get, and this is for kids who only have to enroll once a year. I can't imagine what it's going to be like once we have adults doing it twice a year. And a lot of it happens to take place with the mail issue, is what I've heard. So I would add an additional note that the mail is an issue. We have so many families that live in homes with multiple other families. Their places of location change. They might have unstable housing. There are packets that get sent to some location that they've never even been at, but somehow that's their listed address. It's messy. And I really think we need to get to the 21st century. Most of my families rely on, like, I know this is not going to sound good, but text messaging, text messaging is really the way that they get most of their notifications on anything. If at minimum we can get to email, that would be something. But reliance on the mail to me is like, I just, on my experience of the Medicaid re-enrollment alone, I have a lot of concerns. I also think, again, with what all the advocates said, and I think you acknowledged appropriately, this is already a really complicated process and very, very, very hard to understand. So, I don't think even most people know that this is available to them. So I think knowing that, the more we can make it easier for members to access information, I appreciate that they can put in that initial request via email. I think that's awesome, but really simplify the process, I think, is absolutely necessary, especially as we enter a time where it's already going to be harder for members to stay on and receive the benefits that they should be receiving. And I don't fault Colorado or HCPA or anyone for that, but I'm just saying it's going to get harder. And so we need to try to help people and not add additional barriers, I think, from the state.
Any input or feedback? Sorry.
Sure, yeah, absolutely.
Rachel.
Dr. Jashinsky, thank you for those comments. I could not agree more. It is hard. It is harder than me and my colleagues, than I and my colleagues want it to be. It is harder than it should be. I think we are trying to solve for a very discrete piece of that hard puzzle in a way that may not be perfect, but I think is really, really necessary right now. But your comments are well taken. We did have very extensive text campaigns at the end of public health emergency. Every household got, I think, 5 outreaches, and that had limited effectiveness. We're still going to try every single method we possibly can to keep people enrolled, especially because the way that the requirements in the federal bill in HR 1 roll out, it will impact households, including kids, several times a year, not just once or twice. So we're painfully aware of that and share your concerns and want to do everything we can to keep people enrolled.
This is Manager Schultzke, and in response, I just want to say I appreciate that. I'm not saying that I have a solution, so I'm just going to come here as a really obnoxious person. I'm just saying we don't have to get into like what happened during re-enrollment, but Colorado was like not good, right? We can all acknowledge we didn't do great compared to like all the other states. Now someone had to not, but like I do keep thinking myself of like, how can we make this better for families? What role can I play as a physician to make this better for families? You know, that is where I'm coming from, is just trying to think of how we can do this better, because the impacts when people lose and have to re-enroll in this whole process, first and foremost, they're terrible for the families and the patient, and that's where our focus should be. But they also add a lot of time and expense and frustration for every other part of the system too. So it's not a good system when that's kind of what happens. And that's where I'm headed. But I appreciate your comments very, very, very much. So thank you.
Thank you. Dr. Kennard.
Thanks to the whole team for this presentation. That I'm ready to make the motion on, but not without a quick comment that number one, defining our process around mail feels like doubling down on typewriters in 1981. That being said, as someone, and I'm sure many of you, who has tried desperately to communicate important information to large groups of people, in my case, highly educated, triple degreed people who are literate, speak English, there is just no way to do it to everyone's satisfaction. People are going to say, no one ever told them. We don't matter what we do. That said, that's not licensed not to try. And so I hope that ongoing iterations will include that. And in the meantime, and forever, we'll count on these great advocacy groups. I mean, I can't imagine navigating this without an advocate. And I'm so grateful that I'm sorry they have to exist. I'm glad they exist. And your need is not going to go away no matter what we do. Lastly, accountability. I don't understand how case management agencies work, but to the extent that they can be held accountable, it would be exciting to be able to do that. I mean, they are a third party that benefits that lives because Medicaid exists. And I'm underwhelmed about the value they add. That's my ignorance probably, but in terms of, if you're a case manager for a family, your job is to keep them, or at least if they are eligible, to keep them. So I don't know if there's mechanisms for that for you going forward. But those are really comments, and I'm ready to make the motion.
Excellent. Any other comments from the board? All right. Then without further ado, do I have Dr. Kanar?
Okay, I said I would, especially because I'm gonna leave soon. I move the initial approval of document 2, MSB 25-917B, revision to the Medical Assistance Act rule concerning appeals process, sections 8.057.9 point 11, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
This is David. I second.
Good, thank you, David. All in favor?
Aye.
Opposed? Any abstentions? All right, the rule carries. All right, we are gonna skip document 3 and go straight to document 4. So Cassandra Keller, are you there?
I am here.
Oh, yay!
Yes, I'm gonna try and get off Zoom so the other folks can see my face too.
It's so great to see you in person. Thank you for being here.
You bet.
Next month.
And just to put on the record, if I could, Mr. Chairman.
Yeah, oh, sorry. That's me. That's me. Yes, Rachel, go ahead.
This is Rachel Entrican for the department. I really appreciate the lateness of the hour. It is 12:52. We're gonna try to get through. The reason we're skipping doc 3 and moving to doc 4 is because it is the more time sensitive of the two. And I know that if we lose one more board member, we lose quorum. So without further ado.
Thank you, Rachel.
Oh, thank you.
All right. Without further ado, Cassandra, please go ahead.
Well, good afternoon. It is now after 12 o'clock. My name is Cassandra Keller. I'm our Community Options Benefits Section Manager in the Office of Community Living. That means my teams oversee all of our home and community-based services, as well as long-term home health and private duty nursing. I'm here today to talk about one of the rules pertaining to what we call the Post-Eligibility Treatment of Income, or PETI. And I will go into trying to explain this kind of complicated process. I know we have a lot to get to, so next slide. I know we have a limited time, so I'm not going to rush, but I'm going to try to be succinct. So post-eligibility treatment of income, what is that? It is PETI. That's what I'm going to call it for the rest of this time. It determines how much of a member's income goes towards residential services after those required protections and deductions. So it's cost sharing for the cost of those residential services. The PETI application is something that is used in home and community-based services across the country, and it is a common practice that is approved by the Center for Medicare and Medicaid Services. One of the other components, part of the PETI calculation, is about personal needs allowance. Those are, that is a protected amount of funds that an individual gets to keep for covered basic needs like clothing, transportation, cell phone bill, hygiene items, and approved trust contributions can be deducted as part of this calculation. So one other thing just to mention is HCPF sets a standardized room and board rate. So every person who lives in receives residential services pays a room and board rate. Medicaid cannot pay room and board. So the member themselves pays the provider for what is in reality, food and lodging. And we set that maximum amount. Right now it's like 856 or something like that. And then we also set a floor for how much personal needs amount someone can keep, and then what the maximum amount of what they can keep. So that protected amount. PETI ensures that members only pay what they can afford. So it's all individualized on a sliding scale. We make sure personal spending needs are protected and that payments are consistent and based on verified income. Next slide, please. So PETI is that calculation that is conducted to determine that cost sharing. What does it do? It is applied after eligibility is determined. So this is a post-income eligibility determination. So a member is already determined eligible. They are going to be receiving, let's say, residential services, living in an assisted living or in a host home. This is a calculation that is conducted by a case manager after they become eligible. It determines how much that member is going to contribute to the cost of their care after we have protected amounts deducted. Members are able to keep money, as I said, for personal needs, We also have an allowance for taxes. So if you have a tax liability, we want to make sure you have an ability to pay for that. Some housing costs when those are applicable, and then other non-covered medical expenses. So let's say you have health insurance premiums, you have responsibilities for a community spouse or other dependents. We set aside and protect those monies so that you don't have that paid for to the cost of services. Also to note, not everybody has to contribute to, they may not have enough income to contribute to the cost of care. So if they're only receiving the base amount of Social Security, they pay their room and board, they keep the rest of that typically for personal needs, and then they pay nothing toward the cost of care. So the more money or more income that someone has, the more likely they would pay a cost of their care for services. Next slide, please. So right now, this is the landscape of where PEDI applies. It applies to individuals on the elderly, blind, and disabled waiver, individuals in the community mental health supports waiver, and the brain injury waiver. It is for members who live in alternative care facilities and supported living programs. I want to be very clear that some of the testimony that you may have received in writing or you might hear today, it says that those two types of settings are institutional care, and that is absolutely not correct. Alternative care facilities and supported living programs are community-based settings. They are settings like their assisted livings. They are not institutional in nature. They are offered under our HCS waivers, and they are community-based settings. So as I mentioned, members keep their personal needs allowance, they have those deductions made, and the remaining income goes toward room and board. The issue is that we have a key gap. PEDI does not apply to those individuals in our developmental disabilities waiver. It's creating inconsistency and inequity among our waiver programs. And we need to make that alignment and that equity, because right now we are treating people with different types of disabilities differently. Next slide, please. So why we need this change? We need to fix this equity gap. We need to make sure that this policy applies to all individuals in all settings that receive a per diem payment. So anybody who lives in a residential receives a residential service, the payment is made in a per diem. So that means a provider is paid a set amount of dollars for a 24-hour period. Not somebody who lives in their own home, who receives personal care service, any of the services you heard about. We're talking about residential 24-hour care. And that's what we're trying to focus on, those per diem services. Right now, DD waiver members do not contribute income in that same way. They pay room and board, and then anything over that amount, they get to keep to themselves, which is not the way it works for anybody living in an alternative care facility or a supported living program. Medicaid pays the full residential cost for everyone receiving developmental disability services, those residential services. So we're talking about 9,000 individuals who receive those, 10,000 individuals, excuse me, who receive residential services that don't have the PEDI applied. Previously, back before 2009, the PEDI was required for individuals on the DD waiver. It got taken away because of some administrative challenges. It was not functioning super well. So back when the department, well, when this waiver was over at the Department of Human Services, it got taken away. And then they moved this waiver over to HICPA, and it has not been resumed since that point in time. So we have that inequity in the way those two are applied. Next slide, please. So we have had some extensive stakeholder feedback over the last several months about these rules. We have heard concerns about the financial impact that this could have in cost strain for members with fixed incomes. There's concerns that it could have an impact on ability to afford housing, transportation, and personal expenses. Individuals who have independent living settings where they live in their own home and receive services, or who work, would be disincentivized to continue to work. And that this would have administrative impacts on workload for our case management agencies. Next slide. So we have heard that feedback and worked vigorously with our stakeholders over the last several months. And what we hope you find before you is a very good compromise with our stakeholders on a rule that helps to address those concerns. So number one, the rule applies to all individuals residing in IRSS and GRSS settings. We've clarified treatment of income is an approved trust, so making sure that trust income is protected. We have expanded consideration of household expenses. So we hear under the IRSS benefit, an individual may be receiving per diem services, but also living on their own in their own home. They could be responsible for the mortgage, holding that mortgage. They may have to pay for household expenses like utilities, water, household repairs. We want to make sure that that can still happen. So we are classifying a type of deduction that is household expenses. So that individual would not pay room and board. They would just strictly continue to pay outside of that process. All of those funds would be protected so they can pay their rent, pay their mortgage, and any of those household expenses. So really making sure those funds are protected for those individuals. The other piece that we have done is we are expanding exemptions for individuals to have this petty applied. So if you are working, if you are in the program for working adults with disabilities, what we don't want to see is those folks working really hard to hand over all of their money to cost share for services. That really stinks, and I certainly wouldn't want to do that. So if you are employed, if you are receiving employment services, or you are in working adults with disabilities, you would not have the petty applied. So this would be outside. You would be outside of this process. And that just reinforcing the fact that members with limited income will have little to no contribution to the cost of their care services. Next slide, please. As you've heard a lot of today, this is considered one of those budget saving initiatives because we will be sharing in the cost of these services with the members themselves. The Joint Budget Committee approved this proposal to implement Petty earlier, well, not this month, last month. We are in the process of seeking federal approval to have these changes implemented. We are mirroring this exactly the same way that we apply it for individuals in our other settings. And we already have the infrastructure set to be able to do that within our system, the training created and prepared for case management agencies to ensure that this is as seamless as it can possibly be for them to implement. Next slide, please. That's it for my testimony today. I welcome any questions from you all. I know that it can be kind of complicated to explain what this math is, but I really just want to stress that this is, while it is formulaic in that a case manager follows specific criteria of what type of deductions or what, it is absolutely individualized, and it's not applying something across the board to members and that each pays a certain amount. It's really based on their own individual circumstances.
Thank you very much, Ms. Keller, for the presentation. It was well done. And also thank you for including the stakeholder log. That's always very helpful. So do I have questions from members of the board? For Ms. Keller? No, not seeing any. Chris, do we have any testimony?
This is Chris Sykes. We do. We have Marcella Schifflin.
And is it Schifflin?
You're close. Schifflin.
Schifflin. Excellent. Thank you, Ms. Schifflin, for being here today. I love all the stickers on your computer. That's pretty cool.
Well, thank you so much, Chair and committee members. I'm Marcella Schifflin. I'm a graduate Lend Fellow alumna through CU Anschutz and JFK partner, who you said, a former co-chair of the Colorado Developmental Disabilities Council for Planning and Grants Committee, a published author of a federally supported supported decision-making tip sheet, and family caregiver policy expert through the federally funded Colorado Family Caregiver Collaborative. I'm also a co-primary support decision-making support person for an adult family member who relies on DD waiver services, and I'm testifying from my own history as a caregiving youth. I've submitted written testimony on the Petty Rule, and I come today with 3 compounding concerns. My family member has moved through multiple host home placements in the last 16 months, 4 to be exact, with no continuity and foundational planning documents. Her DVR services were dropped during a regional accountability entity transfer with no accountable party. Her Social Security disability eligibility matter has been unresolved for 21 months. Under this rule as drafted, her income baseline cannot be accurately documented. Her employment exemption is at risk because of a system failure that she did not cause, and placement transition she did not initiate would trigger mid-period recalculations. She is not an edge case. She is a pattern that this rule was not designed to see. The people this rulemaking did not account for are not one group. They are not a small number. They include active duty military families, veteran families, mixed status immigrant households, members whose caregivers are detained or deported, domestic violence survivors, single income households where caregiver loss collapses housing and documentation simultaneously, parents going through a divorce, members who want to move from a host home into a family member's home, caregiving youth, including those approaching the age of majority, simultaneously with a family member with a DD, developmental disability, single parents in the sandwich generation, households caring for both a child with a disability and an aging parent, where any change in that household, a death, a transition to adult services, an illness triggers a petty recalculation they did not initiate. Across Colorado's developmental disability waivers, more than 17,400 people are enrolled today. The rule.
Sorry, Ms. Scheffler, I have to cut
That's
you off.
it? Okay.
That's the time,
Thank you.
but thank you very much. Does anybody have any questions for Ms. Scheffler from the board? All right, thank you very much. Chris, do we have anyone else for testimony?
We have Bryce Rafferty.
Mr. Rafferty. Can't get rid of it. That's all right. We enjoy having you here. Thanks for making it down here today.
Good afternoon, Chair and members of the board. Thank you for the additional opportunity to comment. My name is Bryce Rafferty here representing CCDC. We had two primary concerns regarding this rule and petty protections for DD waiver members living in residential settings. First, in order to avoid disincentivizing employment, exempting DD waiver members who are employed and receiving Medicaid benefits without afforded employment and Medicaid buy-in arrangements. And two, ensuring that DD waiver members living in their own homes have their household and living expenses deducted from their gross income for petty contributions to the residential services. After consulting with us and other advocates, the department's amendments address these concerns. Specifically, the current draft incorporates provisions that deduct expenses from members' gross income to make community living viable despite petty. We also appreciate the rule's construction. All listed deductions are under Section 2, called Case Management Responsibilities, emphasizing how case managers will play a central role in the individualized process of gathering documentation from members about their specific household and other deductible expenses to determine their petty contributions. Furthermore, the rule permits members to retain any income remaining after the cost of residential services is paid from their income. On balance, the rule achieves its Medicaid sustainability goals while preserving individualized petty assessments that include detailed and itemized deductions specific to a given person's living costs. The department will also be monitoring the rule's implementation and its effects on DD members to identify unintended barriers to community living and financial independence. Taken together, we believe the department's efforts to protect and promote employment and community living strikes a fair and equitable balance between fiscal austerity and person-centered principles. Therefore, we support the rule but strongly recommend continuous oversight, monitoring, and ad hoc policy guidance, and plain language resources for members as needed to mitigate any problems identified throughout implementation. Thank you.
Thank you, Mr. Rafferty, and thanks for your ongoing advocacy and for the work you continually do with the members of ICOP to help them get this right. Thanks. Members of the board, do you have any questions for Mr. Rafferty? All right, not hearing any. Thank you, sir. Chris, do we have anyone else signed up for testimony today?
This is Chris Sykes. We do. We have Pat Chamberlain.
Excellent. Pat Chamberlain. Are they online?
Yes.
Excellent. Pat Chamberlain, are you there? Can you hear us?
I'm here. I'm sorry, I didn't see the unmute button.
That's all right. It's, you know, sometimes they just like to hide on us, don't they? All right.
Hi, I'm Pat Chamberlain. I'm mom and a legal guardian of a son, 29 years of age, and on the DD waiver. Applying Petty to the DD waiver members fails legally by its intent, ethically, financially, and personally. It fails legally because the DD waiver is defined as access to 24/7 care, not as a residential setting. It fails by its intent to allow people with IDD to keep only $14,940 a year, which is well below the federal poverty limit. It fails ethically because HCPF continues to falsely state that people on all other waivers have Petty, but people on any other waiver live in their own homes, as people do on the DD waiver. Petty is not applied. It fails financially. HCPF bases its projected budget savings on the false information that almost 4,000 people on the DD waiver have income over 300% of the federal poverty level. Prior to Medicaid buy-in, in order to be eligible and retain any waiver, income must be below 3 times SSI. That is far less than what was used in HCPF's budget projections. With the latest iteration of rules 2 days ago, HCPF has exempted earnings from Petty. That leaves people with IDD who are unable to work, the only ones who will bear the brunt of Petty. If those members rely solely on SSI as their income, it's too little for Petty to be applied. If they rely on SSDI from an average retired parent's Social Security, it's also too little for Petty to be applied. If it's not wages, SSI, or SSDI, please ask HCPF where the income that Petty will be applied to coming from and what the recalculated budget savings is now that Petty will not be applied to those who work before you approve taking income from the most severely disabled with very little cost savings. It fails personally because we are in our 70s and we count on our son being able to keep his SSDI that he receives from his dad's Social Security when we die. He has a part-time job landscaping that he does in the summer, but in the months that he does not work, about $500 would be taken out of his SSI. Applying Petty to DD waivers members is discriminatory against people with IDD and fails on all fronts. And we ask that you do not approve this. Thank you.
Thank you very much for your time. I'm sorry, your time's up. I do appreciate your testimony. Is there anyone from the board that has a question for Ms. Chamberlain? All right, Ms. Chamberlain, thanks again for your time. Mr. Sykes, do we have anybody else signed up for testimony on this rule?
This is Chris Sykes. We do. We have Charlene Wiley, but Charlene is not online. Charlene in the room? If not.
All right, who else do we got?
Next up is Maureen Welch.
All right, Miss Welch, are you online?
Yes, can you hear me okay?
We can. Thank you very much.
Thank you. So my name is Maureen Welch. I live in Arapahoe County, and I'm the parent of a current DD member, or DD waiver. And I also support many families online in educating themselves on all things Medicaid. I'm also a recovering special ed teacher from 18 to 21-year-olds doing internships at Project Search at Children's Hospital and a recovering vendor of the Division of Vocational Rehabilitation Employment Services. I oppose the timing and the idea of this Petty rule. I find it absolutely fascinating and mind-boggling that Colorado invested in creating the Office of Employment First here in Colorado to encourage residents with IDD to work. And yet we're contradicting our own office, saying that we will now punish people on the DD waiver for working. Oh, but a person can do the buy-in program as a workaround, right? All that's going to do is drive that line item of administrative work for HCPF, and then they're going to come back with another supplemental request. Again, I hear my grandma, penny wise and pound foolish. The current way to access employment services is not easy, and finding a quality waiver accepting employment specialist is most challenging. I appreciate the consideration of household income or household expenses and calculating that for the deduction, but that's yet another administrative burden, which is discriminatory because it only will work if that person has friends or family to volunteer to accomplish that task. This rule creates a disincentive to true belonging in the community through employment. This is Olmstead, the whole purpose of having home and community-based services. It's easier to go to a day program and drive those line items up than work if you pass this rule. And I oppose this because it punishes those on the DD waiver who want to work, and it will drive up costs for the states in areas like day program, transportation, and the buy-in program administrative overhead. Please vote no. Don't disincentivize working for DD members. It does have outcomes that increase health, mental health, and save the government money by letting people work. Thank you for your time.
Ms. Welch, thank you for your time. Members of the board, do you have any questions for Ms. Welch? All right. Mr. Sykes, do we have anyone else signed up for testimony? Thank you, Mrs. Welch.
This is Chris Sykes. We have Christine Wood. Again.
Miss Wood, are you there? Oh, look at that.
I was going to say, we keep finding.
You've been hanging out for a long time. Thank you for being here.
Thank you for all your work you're doing this month. I think it's very fascinating. I am here. I'm here representing myself and my family, no one else. My daughter is 21. She's actually about to transition out of the 18 to 21-year-old program. And actually just yesterday, she got offered her first 4-hour stint at Habitat for Saturday, which much to my surprise, she's psyched and she wants to earn, as she said, because she wants to make money. Anyway, so that is why I'm here, because I think it'll be a bit easier, because I read through the rule and I have not yet seen any of the actual nitty-gritty details, but the two things that jumped out at me are that it is not exactly how she'll be able to retain her income by, and how that will be set up by July 1st, and maybe because that stuff has not been published to us. But at one place it said, it sounds like it's really easy. I talked to the case manager this morning. She said, oh yeah, not a problem to enroll her in this one program. But then elsewhere in the rules, it says that it will be determined on a case-by-case basis. I have a feeling we're going to end up being sort of case central for these changes. And so I just won't get upset of the things that happen over the next few months. But I wanted to raise that and make sure that you clarify what case by case means. Do we have to go through some arduous process so that she can make $100 a month, because HCBUF is counting on getting $500 a month from her to balance the budget, plus the federal match that I think is in the budget as well. I thought I saw that at some point. Anyway, it doesn't matter. So I just want to make sure that that part is actually mapped out from the view of me working with the case manager to figure that out. And she also has medical issues. So 1 month she might not be able to work. 1 month she might be able to. So how does that work for somebody who is medically fragile and she has seizures? So how flexible or difficult will that be?
Thank you very much. And members of the board, do you have any questions for Ms. Wood?
Thank you.
Thank you. Mr. Sykes, do we have anyone else signed up for testimony on this rule?
This is Chris Sykes. We do not have anybody else signed up for testimony.
Okay. On that note, I look to you again. If you could share with us your thoughts based on what you've heard from the group.
So this is Cassandra Keller. As Russ, I will try and answer thematically just a few things in response to the questions that were brought up by Christine here. The case manager is responsible for working with that member during their continued stay review. So during the time where they're authorizing services, there is an Excel form that's actually available online, so you can see it. And it is a worksheet that talks about, okay, what is your gross income? It's provided by the member. They say, show me, do you have non-covered medical expenses that you need to account for? Do you have a tax obligation? Do you have someone that you are responsible for out in the community? They go through that worksheet, they enter in that, and it spits out a calculation. So while it is standardized, as I mentioned, it is on a case-by-case basis in that it is absolutely individualized based on each person's circumstances. This is absolutely a legal process that we already have approval from the Center for Medicaid and Medicaid Services to do in our other waiver programs. It is absolutely allowed to have this cost sharing mechanism. So we are able to do that for our residential benefits. I understand that there are some nuanced differences in the fact that someone may live in their own home while receiving residential services on a DD waiver, but they are still getting residential services. It is paid in a per diem, and therefore we have the authority to require cost sharing for those individuals. One of the statements that was made is just factually incorrect in that we are only making allowances for those in the Working Adults with Disability program. We heard from our stakeholder friends, hey, that's not going to capture everyone that works. Well, that's a good portion of them. That's not everybody. And if you only allow that, you are going to leave a large cohort out there who is working and will be disincentivized to work. We said that is not our intention, not what we want to do. And we said, okay, let's make sure we are covering those who are receiving employment services. We said, that's great. You still have a little bit of a grouping that may get left out. So it is anybody who is employed has that exemption. They will work with their case manager, say, hey, I am working. It can be seasonal. The petty is not something that a case manager is going to do every single time circumstances change for an individual. So if they are working seasonally or minimally, that's okay. They share that information with their case manager during the authorization, the service planning process, and that's set for the year. So it is absolutely allowed that an individual work and not be disincentivized. We are not doing that. They will not have the petty applied. And then the last thing is that I understand that this is a big change and a shift for individuals who will be on the DD waiver if this is applied to them. But this is the same process and the same financial situation that all of our members living in alternative care facilities and supported living programs face. We do not want to look at individuals who have an IDD and say you are different, special, unique, and you should have some process very different than other people who have disabilities and live in community-based settings. We want an equitable, consistent practice across the board and not calling out one direction or the other. So to say that it's illegal to allow someone to only keep their SSI amounts or have a personal needs amount, that's not true. That is exactly what is happening to those individuals in our alternative care facilities. Thank you.
Excellent. Thank you very much. Does anybody have questions for Ms. Keller from the board?
Yes.
Dr. Kennard.
Thank you. Just a quick question. What is your response to the letters that call into question the net gain, the net savings from this? They seem very pessimistic about any realized savings.
Yeah, this is Cassandra. That's a good question. There will absolutely be net gains if there is a cost sharing. Now, we will probably realize a little less than what was initially estimated because we did not carve out all individuals who are working. So it will be less than what was projected. But, we see individuals in all of our different residential settings with varying amounts. So I do believe we will absolutely see cost savings when we have cost sharing occur. But I don't know, now that we have adjusted the regulations to allow for all employment, I don't know exactly what that math would look like.
Dr. Kennard, does that answer your question?
Yes, thank you.
Anything else from you?
Thank you.
Excellent. Dr. Shlesinski.
I think it's always good to just have, as Dr. Amanda Shlesinski, for the record, like, this was helpful earlier, explanation of what could happen to the program should this cost saving measure not be implemented.
So this is Cassandra. We are trying to not cut services to individuals who have critical service needs. So we want to make sure that we are exploring other options. This is a great option for us in which members are able to still continue to access their critical residential services and have a cost share into that. So this allows us to tap into a resource without creating a reduction to services. And at the same time creates equity that has been a long time creating a gap in how we treat individuals with disabilities.
Thank you.
Dr. Jaslinski, any other questions?
No other questions.
Excellent. How about from other members of the board? Anyone online? All right. Cassandra, thank you very much. With that, I would entertain a motion on this rule.
Can take that.
All right, go ahead, Dr. Jaslinski.
Remove the initial approval of document 4 MSB 25-10-22-B revision to the medical assistance rule concerning the post eligibility treatment of income, section 8.202.BB incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Dr. Jaslinski. Do I have a second?
I'll second. It's JK Bissell.
JK, thank you. All in favor?
Aye.
Aye.
Any opposed? All right, any abstentions? All right, that passes. Guys, we have been at it for 2 hours, and so we are gonna take a 5-minute break to go to the bathroom, and then we'll come right back. Oh,
I think when we come back, we're gonna need to check if we still have a quorum.
Yeah.
oh, okay.
I was gonna ask if I could do my proxy. Okay. Not cool.
Yeah, but you're not the only person who may need to leave in the case where we need to make a.
Well, then why, maybe we just do that before we go then, just to.
Sure.
All right.
Sure.
Cause that might.
I know Dr. Mulkey says she has a hard stop at 1:30.
That's
And that's it.
Yeah, we're not gonna be able to give any, maybe we,
And then that would just make 5 board members.
So no quorum.
no more. All right. So should we maybe do updates real quick? Or just close the meeting? What do we think?
Oh, well,
Okay,
me personally, I would vote for the individuals that wish to give public testimony, because public testimony is actually spoken to Miss Adela down there and.
okay. I like that idea.
But so but don't close the meeting first and then do.
Yeah, we close the.
Well, I mean, we do the closing motion for
Yeah.
rules.
Yeah, thank you.
I'd like to entertain a motion on the 2 rules that we passed. Do we want to move either of those to the final adoption or the consent agenda for?
This is David. I would like to take the first rule off of consent agenda so that we can hear back about alternate communication methods that the state said they were going to work on.
All right, and that's document 2, correct?
Correct.
Yeah.
Correct.
So- And then
Heading you just heard.
what on the one we just heard, document 4, is there an appetite to move that to the final consent agenda for next month?
I concur.
We don't need a motion.
No.
You just made the motion, as long as, right, and as long as the discussion is discussed. Yeah,
All right,
so 4 is going, how about you just read the closing motion for the rules? You don't.
there we go.
And we don't need a vote.
Okay. I move that all rules adopted at the meeting of the Medical Service Board of the Colorado Department of Healthcare Policy and Finance meet the criteria of the State Administration Procedures Act, which are incorporated by reference.
Okay.
All right, so that is a closing. Do we need?
The rules are closed. This is Chris Sykes. The rules are closed.
Now we go to the issue.
So unfortunately, the board members that have a life outside of this board table still to go to, the rules are closed. So, yeah, but we can still do public testimony.
Not associated with.
Not associated.
Yeah, that's just par. And then, yes, department updates could go forward. Don't know if you want to call a 5-minute break, but.
Yeah, let's do that. Let's do a 5-minute break and then come back and we'll do open forum for public comments. This will be for public comments not related to any of the rules. So thank you guys. 5 minutes and we'll be back.
In Pueblo next month.
Yeah,
It's hardly wait. Thank you for taking time.
I know that.
All right, guys, thank you very much for giving us a few minutes to hit the watering hole. I think at this time, what we're gonna do is we're gonna open it up for a public forum. All comments will be limited to a maximum of 2 minutes unless scheduled in advance. Oh, thank you.
Here's the official.
During the open forum, the Medical Services Board welcomes the public to share testimony with us about matters not on the regular agenda. Please note that this board is a rule adopting body only and has no authority to address concerns or grievances against the department or its contractors. Testimony is limited to 2 minutes. Thank you in advance for sharing your time with us. And just as a reminder, this should be things not related to rules that are before the board. So, Mr. Sykes, do we have folks signed up for open testimony, open forum?
We do. First up, we have Phoebe Blessing, who has been with us all morning, part of the afternoon.
Phoebe, thank you so much for your patience and thank you for being here.
Well, thank you for all of the work that you do.
So it's our pleasure, really.
Great. Should I just get started?
Yes. And then your time will start once you get going.
Excellent. My name is Phoebe Blessing. I'm here on behalf of the Colorado Hospital Association. I want to first just acknowledge that this has been a long and difficult day, and we are deeply grateful for the time and care and engagement that you bring to this work. At your last meeting, the board expressed interest in learning more about the 340B program. Given the significant access to care implications, particularly in today's resource-constrained environment, we wanted to be responsive to that request and serve as a resource by providing additional background on why this program was so important. The 340B program is a lifeline for Colorado patients, especially in communities where options are limited and resources are stretched thin. It allows hospitals to provide free and reduced cost care, ensure patients can access life-saving medications, and sustain critical services like behavioral health, oncology, and rural care. For many patients, this program is the difference between them getting treatment and going without. At the same time, hospitals across Colorado are under significant financial strain. Costs are rising, reimbursement isn't keeping pace, and a full 85% of our 340B hospitals are operating with unsustainable margins. In these conditions, 340B doesn't create profit or excess. It fills gaps to allow hospitals to keep services in place and continue caring for their communities. Last session, the legislature addressed 340B transparency through Senate Bill 2571. That law was the result of extensive negotiation and stakeholder input and reflects a careful balance, providing transparency while preserving hospitals' ability to use these resources to meet local needs. Because every dollar spent on new administrative requirements is a dollar that is not going to patients and communities. We appreciate the board's engagement on this issue, and we welcome the opportunity to continue providing information and examples of how 340B supports patients and communities. Thank you.
Thank you very much. Board members, do you have any questions? Thank you so much for your time. I really appreciate you.
Thank you.
Mr. Sykes, do we have anyone else signed up for public testimony?
We do. We have Kristen Weisinger.
Yes, and I will. So Megan Exler with the Colorado Hospital Association to be responsive to the board's feedback. As well, we had a number of hospital experts and representatives who are signed up online. We are now going to be sending you that over email. So the wonderful Chris Sykes will give you that feedback and that background from our partners to let everyone get to their weekend.
Thank you. Thanks,
Thank
Megan.
you, and thanks for everything the Colorado Hospital Association does. We really appreciate you guys. Thanks.
Thanks for hanging in there.
Thanks so much.
Mr. Sykes, do we have any other public testimony?
We do. This is Chris Sykes. Erica Pike.
One of
she would.
well,
Okay.
Jennifer Riley and Audrey Boyd are the others, and those are all hospitals who are prepared to provide.
And Thomas was to speak. Looking longer.
Okay. Thank you very
Thanks all for the opportunity. Yeah, just like Megan and Phoebe said, I've submitted my comments to your email, Chris. Thanks again, everyone.
Thank you.
And thank you guys for your willingness to do that. That means a lot. Appreciate it.
I have a question.
JK. Yeah, JK, please.
What's up?
I got
So one of my questions about was that it seems pretty weak, the transparency requirements, frankly. So what would that look like to like put some meat on that and say what what reporting should look like for 340B? I guess we weren't part of the stakeholder, like the discussion of the legislature, we got a really nice email from the governor right now about that. And so I mean, that was my issue with it. There's nothing to it.
I think that's a fair question. To be completely honest, the measures that were passed in Senate Bill 71 last year now make Colorado have some of the strongest transparency requirements in the country. And it was, as I said, heavily negotiated. This is something that there were hours and hours of testimony from hospitals and patients and pharmacies explaining, all of the oversight that already exists within the program. So one of the folks who we had planning to testify today, I met with him yesterday, and he was like, we actually just got audited on Monday about this, so I can speak to that. So there are regular audits. HRSA does a lot of work. So there is quite a bit of oversight already. I think there's just sort of a fundamental misunderstanding of this program and how it functions and what the transparency actually looks like.
JK, do you have any other questions?
I appreciate that. There was, this is JK Costello. Those, or I don't recall those from our briefing, and that might be helpful for us to know. Because I'm sure that this is not some fly, like I know 340B pretty well. It's not a fly-by-night program, but I also don't know the back end reporting, the audits and things like that.
Yeah,
So,
absolutely. We can provide information on that. So this is Phoebe Blessing. Yeah, happy to do that. Anything you would add, Megan?
No, and this is Megan Axelrod, also with the Hospital Association, just to echo Phoebe's comments. The transparency provisions in Colorado that are set to kick off in July are some of the most robust in the country. That I'll be a little blunt, we saw a lot of bad faith during the legislative process when it came to just misinterpretations. And so we are here to serve as a resource to provide background on the great work that does happen and the technicalities when it comes to the transparency side.
you're welcome.
Thank you, guys. Any other questions from members of the board? Excellent. All right, Mr. Sykes, do we have anyone else signed up for public testimony? Thank you, guys.
This is Chris Sykes. We have Ginny Arrington.
Miss Arrington. Are you there?
Hello.
Hi, how are you?
All right, how are you guys?
Fantastic. What you got for us, Miss Arrington?
I would just like to express my frustration and sadness. We are really looking to you guys for advocacy alongside us rather than just all this misunderstanding and confusion. I really want to express how important it is for my family and how deep and urgent it feels to give life-sustaining care 24/7 when we're in a rural area and it's really hard to access extra care. And I know you've heard this and I know you've expressed that you have a heart for it and this is hard, but that's not enough. We need action. We need help. I would also like to also comment on what Maureen Welch has said, giving a lineup for when it's time for members to have a turn in testimony. I think that would be really helpful. It's really hard for myself to turn off and not be hyper vigilant while giving a testimony. I appreciate the time today. Thank you.
Thank you, Ms. Arrington. And I do appreciate the comment. Well, I won't speak for the what I can tell you is I work in a rural community. I work in a rural setting. I come in contact with families that provide my services every single day. While I don't know exactly what your struggle is, I do that my heart is with folks in the rural communities that are struggling to meet the needs of their family and their communities. And
I would be happy to schedule an outside time where we can have a Zoom and you can see us face to face and why it feels very hard for us, so that I'm not divulging medical information. I would be more than happy to schedule a time.
yeah, feel free to reach out to Chris, and you are welcome to have my contact information. I'd be more than happy to follow up with you on that.
Thank you.
So, and again, this is from the bottom of my heart. I really do appreciate your time, and I want you to know that while we're not always able to do everything that folks come and ask for, we do advocate for you every step of the way in everything that we do. I know it doesn't always feel that way, but you are heard and you are seen. And I very much appreciate you coming and being part of this process. Does anybody else from the board have any comments? All right. Thank you very much for your time.
Thank you.
Mr. Sykes, do we have anyone else signed up for testimony today?
This is Chris Sykes. We have Victoria Mao.
Miss Mao.
I'm on a roll today.
We appreciate you. Thank you very much.
Oh my goodness. So mine comes as a parent, first of all, always as a parent, but also as an advocate. I know that there are many different players in this. There's the JBC, there's the House, the Senate, the long bill, you guys, appropriations committees. Oh my gosh, the list goes on. You need an assistant for your assistant just to keep up. And I have asked every single one of these groups, so it's only fair that I ask you. There continues to be a lot of push to do things very quickly without a tremendous amount of insight and understanding. I'm going to give you one example so that you can understand what I mean. A memo was put out saying that CC hours were going to be dropped immediately starting April 1. And then another memo was put out the other day stating that would be changed to annual review because of the mess that it caused. And I would like to point out, an advocate group pointed this out to that agency. The agency ignored it. And then we at Impactors got legislators involved who then went back to that agency and called them out and fixed this. There's not enough oversight. There's not enough fine line item on this. There's not enough accountability. And so even on the policies you guys are voting on, they're already happening. You guys didn't even really need to vote on them. And as the MSB board having a tremendous amount of power, I think maybe you should call people out on that. Just a thought.
Miss Mal, thank you very much. Does anybody have any comments for Miss Mal or questions? I appreciate your time. Thank you very much. Mr. Sykes, do we have anyone else signed up for public testimony?
This is Chris Sykes. We have Kelly Lyons.
Miss Lyons, are you there? Miss Lyons, are you still online? Okay, and did we lose her?
See Kelly Lyons online.
I think she was off, and when she was on the earlier too, I think we missed her. So, all right, Mr. Sykes, do we have anyone else signed up for public testimony?
This is Chris Sykes. We do. We have Veronica Baker, but I'm not seeing her either.
Yes.
Oh, you're there.
Oh, hey, Miss Baker, how are you?
Doing well, thank you. Hi, my name is Veronica Baker. I live in El Paso County. I have 4 kids. My oldest are twins, 17 years old, both with autism and both with developmental disabilities. And I am concerned about the Medicaid cuts being proposed in general, especially when there are astonishing records of Medicaid fraud that have been committed recently and have been put out into the news. As a member of a family who greatly relies on these Medicaid services, I am concerned that the most vulnerable population is paying the price due to others' negligence and others' greed. And I know that I'm not the only member of the public feeling this way, and I just wonder what we might do to restore confidence, to restore trust. It doesn't seem like we're acknowledging that the people who are absorbing these cuts are feeling jilted, if you will, for other actions that they in no way had a part of. So I would just love to kind of see what we're going to do in a sense of like addressing that and helping others kind of understand that, you know, this isn't just the lot that they're in. So those are my comments. Thank you.
Thank you, Ms. Baker. Any questions from the board or comments from the board? Ms. Baker, I thank you for your time and we hear what you're saying. We do. Mr. Sykes, do we have anyone else signed up for testimony?
This is Chris Sykes. We have Maureen Welch.
All right, Miss Welch.
Hello, can you hear me okay?
Thank you for hanging out with us today.
Sure. So I have a question before you start my clock.
Yeah.
Just a point of order. Is there a way that you can tell us who is still on this call? Because this webinar format doesn't tell us who from the board, who from HICPUF is there. That would be really appreciated.
This is Chris Sykes. I can tell you the board members we have are James McLaughlin, Amanda Jaslinski, and J.K. Costello. And then we have Adela Flores Brennan in the room, Bonnie Silva, Jennifer, Rachel Entrekin, and myself, Chris Sykes.
Okay.
That is it in.
So three board members are left then.
Correct.
Yes, ma'am.
Okay. All right. It's a little disappointing, but I will forge forward. Thank you to all the members, the 3 that are left, and those who have already had to leave, for volunteering your time and speaking up about injustice, even when HICPUF uses the JBC authorized this budget excuse. And thank you to the HICPUF staff who work very hard. And most of all, thank you to all those families and advocates who stuck around for almost 5 hours here of MSB. This is just a fraction of our community who have a unusual privilege of time and bandwidth to attend these meetings. Thank you to HICPUF for sticking to, or for posting one slide deck before the meeting. You posted it yesterday. That was awesome. I would love to see this for all the slide decks, all the presentations, at least one day before, so that when we make public comment, it can be based on the most updated information. And that is a reasonable accommodation for public engagement. Also, some people make their comment written, so having that available to review before they submit written comment is super helpful. I also want to thank the chair for having HICPUF hold all of their comments until after all public comments were made. This has been a real problem in last meetings, and it took a lot of time, so that's a huge improvement that I want to recognize and thank you for. Lastly, a request to Mr. Sykes that we consider putting in the chat the list of signups for each rule so that we can be ready, as the last speaker, one of the speakers recently said, to speak, because a lot of us are multitasking. I'm about to jump in the car and go get my son from school, and it's nice to know when our order is up. And it would be nice for you to put that in the chat for us to see. This is how the Cherry Creek School Board does it. Yeah, believe it or not, I go to more meetings than the MSB, and it works really well, and people can go a lot quicker when they're prepared. It is a reasonable accommodation, and it reduces anxiety, which then will increase public engagement. And lastly, I want to welcome Gretchen Hammer to the department. I'm thrilled to have her at the helm, and I am feeling a sense of optimism to improve things at HICPUF with communication, and also I see some improvements in the MSB process. So thank you, everyone, and I hope you have a wonderful weekend.
Ms. Welch, thank you very much for your comments, your suggestions, your recommendations. It does help us improve processes. So thank you for that. Any members of the board, do you guys have any comments or questions? So thank you very much.
Oh, I have one.
Oh, JK, go ahead.
I feel like we have done the 3 members ahead before. No, I've seen it done in other meetings and I liked it. So I hope we can consider adopting that somehow.
This is Chris Sykes. Yeah, Kelly and I will definitely talk it through.
Okay.
We do have challenges, but we are willing to investigate. Cool. Yes.
Thanks, Chris. I appreciate that. I'll tell you, and I just want to say the unsung hero in this whole process truly is Chris. I mean, from getting all of us corralled and here on time and helping us get everything we need to be here and having all of our materials and corralling all the stuff, and Kelly with corralling all the folks online and making sure that it goes as smoothly as it does. It's just
be there without Kelly.
And Kelly. I mean, it's a whole team effort, but those two, I just can't say enough about the amazing work they do, and then the work they do throughout the rest of the month to answer our questions and to have information to us so that we can make the best decisions possible. So thank you.
Thank you, Kelly, and thank you, Mr. Sykes.
All right, thank you.
Buenos Mas.
Oh, okay. Who else do we have, Mr. Sykes?
We have as our final contributor, Megan Bowser.
Ms. Bowser, thank you so much for being with us all day.
Anytime.
Really,
we
love your comments.
Thanks. Thanks for the opportunity to speak to you one last time today. I stuck around, bring back a topic that's an oldie but a goodie. I've testified to this board many times about ongoing problems with access to private duty nursing. In 2024, this board worked extensively to revise the PDN rule with the expressed intent not to restrict access to PDN or tighten eligibility, but to provide clarity in response to rising denials. Unfortunately, this issue has continued to escalate. The state's published data shows that full PDN approvals fell from 85% in 2023 to 76% in 2024, and then down again to 64% over the last 12 months. This isn't just a reduction in hours. Full denials in that same window rose from 2 to 3% in 2003, 14 to 14.5% over the last 12 months. A dramatic change. When PDN is denied or cut, families are the ones filling the impossible gaps in care when children with complex needs are put at risk. These families of medically complex children are facing the cuts you've heard about earlier today around the sustainability measures and are simultaneously losing access to the only service that realistically provides them with qualified and safe alternative caregivers. Amidst all the other issues we are seeing brought to this board, I wanted to reflag this issue as one that, despite tremendous effort from the boards, has still not been resolved, and we will continue to bring it back up in future meetings. Thank you so much.
Thank you, Ms. Bowser. I really do appreciate that. Any questions for Ms. Bowser? All right. You have a great weekend, my friend, and we look forward to hearing from you in the future. Keep up the good work. With that, open forum is closed, and I think we're ready for adjournment. So,
as long as Adela has nothing
Adela,
pressing.
yeah.
You've sat here all meeting. Do you have anything pressing in your department update?
The big one.
There's just a little change.
Staffing.
Staffing.
One is the staffing change. The executive director, Gretchen Wool, was confirmed by the full Senate this morning and will start with us on Monday. She is known to the department, has been here as the past Medicaid director, national expert in Medicaid. And then, of course, the budget is going through, and there's a lot to report on that. And it's getting amended still. And so I think the best thing to do would be to hold that full briefing until next month when we know exactly what has happened. So
Thanks.
keep it short and sweet.
Thanks, Adela. All right, anything else?
Question for Don.
Yeah.
Will we hear from the new director? at some point?
I'm sure.
Yes.
Yeah. She has an all-staff meeting to introduce herself, next Wednesday or Thursday. And then, we can get her on the agenda specifically for MSB for next month. I'm assuming you meant we, MSB, not we, the giant public. I'm sure both are going to happen. I just.
Yes, I meant MSB.
We will, look at a future meeting for an invitation.
Can I ask a completely different question? All the things that we didn't get to today, are they gonna get pushed to next?
Future meeting.
Future meeting.
Yeah, we're gonna have to figure out what stays on May and what needs to move further out.
Yeah, so.
That's an internal leadership discussion. we'll have to
And,
have.
and typically, just so you're aware, so rules coming to Medical Services Board initially go to a department program, department meeting, public rule review. Bill gets emails. He gets emailed what rules are going to be on the public rule review. I can certainly add you guys. He just likes to know. So, yeah, we have a number of rules already coming.
No,
Yeah.
that's why I guess, yeah,
Kyle and
just adding to problems without solutions, because that's like my theme for the day, but I guess I'm curious with your guys' experience. There's gonna be a lot of spicy stuff ongoing for months. These take out, I mean, we spent 2.5 hours on that first one. I cannot continue to do, like, we have, Cassie Littler has to be in clinic at 1 p.m. every Friday. We have other people who have to leave earlier, and I just don't know how to improve the process or do this in a way that's sustainable through all of this, and so that we have enough board members to have forum every time. So I just bring that up as something that I'm already concerned about for next month. Because I really appreciate all the discussion we had on the first, like, I would have been absolutely not comfortable at all voting on it without that. That being said, you know, when we have something like that on the docket, I don't know how we would expect to hit the other 5 or 6 that were on the agenda for today. Like, I would have looked at that and I would have been like, that's enough. Like, you know, so I don't know what to do, but that's just something to bring up, because I just feel like it's gonna continue to create, like, actually worsening pressure as it backs up.
Yeah, I think that's a really fair point. I think I will tell you, we've never seen anything like this before.
Yeah.
So during the public health emergency, we had a lot of emergency rules.
Yeah, right.
We even had special sessions where we were doing sort of like mid-month stuff for like 2 days in a row. But that's when we were flush with cash. We had ARPA. We were all like, there was no conflict about like, these are the rules that need to change to keep people safe from a disease none of us had ever seen before. This is exactly the opposite of that.
And that's always gonna hurt more, and it's gonna bring up more testimony. Like, this is all expected, and I think, you know, appreciated, heard, you know, necessary. But I just look at this volunteer board and what other commitments people have. And I'm worried about just the ongoing sustainability of how this process is unfolding.
Yeah. What are the other type 1 boards doing? Do we know?
The other type 1 boards are not responsible for 1/3 of the state budget.
That's true.
So that is one thing I know, but also you might have a little insight into some of the other boards.
Board of Health is business as usual. I don't know about like DHS.
I think DHS is struggling
with
too. I don't know if you've talked to your counterpart there.
I can reach out.
Because they have a lot that they're responsible for, and with the BHA stuff, and
Yeah.
I can't imagine that they're not having similar.
And I think everyone's doing a really good job, like trying to move people quickly, respond to everything, you know, at the end and thematically, but And
I can tell you,
take a certain amount of time. Like,
we've
it's
done
gonna take
stakeholder engagement since October on most of these regulations. I mean, hundreds
Yeah.
and hundreds of comments we've been responsive to. We've heard people who've made changes. And I'm going to, and even with as much support as we have, we will probably have the same people show up for every single one and want to testify.
Well-
So that is going to happen.
Or then testify on multiple things. So I guess I don't know. Again, like I said,
Yeah,
I'm
no, it's-
raising a problem without a solution, but I just am a little concerned personally, for myself personally. Like this is not.
I think it's a totally fair concern
Yeah.
for you and for
Yeah.
the entire board.
Go ahead, JK.
This isn't a solution, but I mean, one suggestion. I was called about this board on a Sunday. It's in my application on Monday, and it was explained to me as we meet 9 to 12,
Yeah.
and it's done at 12. And I was like, oh, cool. I can,
Same.
take a half day off, but then I'll be free. So for my first few months, I had meetings stacked up starting at 12:30, and I've learned
That's
that's not the case. And that I was oversold, and I'm happy I joined the board, but also like I would get on the same page with recruitment of you're here from 9 until whenever it's done. And sometimes that'll be 11, sometimes that'll be 12, and sometimes it'll be 2. And I could have made a better decision. I'm not saying I would have made a different decision. It was just like I'm kind of just now getting to where I know not to schedule anything until 3:30
Well, and
on Fridays.
I am not my own boss.
Yeah.
And this is getting spicy. Like I'm just letting you guys know, like Adela knows, I have another job and I just am, not, I don't know. I keep waiting, like thinking, okay, that was like a fluke in November, maybe if we can, and this is not a year, but like, I don't know. So I put that forward, but I will not be joining you lovely people in Pueblo because, yeah.
Those will be best.
No, thank you. Yeah.
Really appreciate you
Be
sticking
patient,
around.
so Thank you.
Every time that you can.
But, yeah, all right. Well.
We lulled you into false.
Plateau pretty much. It was not only 9 to 12, it was a 2-year commitment. Then I found out it's not whenever a 4-year commitment times 2, and I was like,
Oh.
Would there be
We let you.
Yeah.
Would there be any appetite?
Blame her.
Yeah, I'm totally thrown under the bus.
She does. To us too. She's like, you like
Yeah.
this project, it'll be super easy. Yeah, I'll like this Kristen. Dell and I have been christened a few times.
Kristen, it's a verb.
It's funny also because there's somebody else who presents to us named Kristen.
Christine Bates.
Christine.
Yeah,
Oh, yeah.
Confusing for everyone.
Yeah.
Well, thank you all for
Thank
your
you.
time, because I know it's not easy for you all either, so I
We
appreciate it.
appreciate
very
you.
much. I think I know somebody.
You guys.
Adjourn.
Now you get.
Oh, did I not adjourn?
You
Oh.
did not adjourn.
Meeting's adjourned.
7:30.
Driving to work.